Welcome to rotator cuff, lesions and tears. Rotator cuff pathology is one of the most common musculoskeletal conditions we encounter in clinical practice. It affects millions of adults worldwide and places a real burden on healthcare systems, workplaces, and individual quality of life. The rotator cuff is made up of four muscles: the supraspinatus, infraspinatus, teres minor, and subscapularis, along with their confluent tendinous insertions on the proximal humerus. Together, these structures serve as the primary dynamic stabilizer of the glenohumeral joint. When the cuff is compromised, whether through degenerative processes, acute trauma, or repetitive microtrauma, the resulting spectrum runs from tendinopathy and partial thickness tears through full thickness tears and, in advanced cases, tear arthropathy with secondary glenohumeral osteoarthritis. The sheer scale of rotator cuff disease is remarkable. The landmark Finnish imaging of shoulder study, known as FIMAGE, found that 99% of adults aged 41 to 76 years had at least one structural abnormality on magnetic resonance imaging, or MRI, and yet the vast majority of those findings were completely asymptomatic. The 2025 American Academy of Orthopedic Surgeons, or AAOS Clinical Practice Guideline, reports a similar picture. 54% of asymptomatic patients over 60 years of age show rotator cuff tears on imaging. These data highlight a clinical principle we really need to internalize. Structural findings on imaging must be interpreted in the broader context of the patient's symptoms, functional status, and psychosocial circumstances, not as automatic indications for intervention. Given this reality, contemporary clinical practice has increasingly adopted the umbrella term rotator cuff-related shoulder pain, or RCRSP, to describe the spectrum of symptomatic rotator cuff conditions. This terminology, endorsed by the 2025 Journal of Orthopedic and Sports Physical Therapy, or JOSPT Clinical Practice Guideline, authored by de Mullis and colleagues, reflects a biopsychosocial model. It integrates pathoanatomic findings with psychosocial contributors, pain neuroscience, and patient-reported functional limitations. The shift toward RCRSP moves us away from exclusively structure-based diagnoses and toward a more thorough, patient-centered framework for assessment and management. Conservative management, including structured exercise therapy, patient education, and judicious use of pharmacologic adjuncts, remains the first-line approach for the majority of rotator cuff presentations. Surgery is reserved for specific clinical scenarios, most notably acute traumatic full-thickness tears in young, active patients and chronic tears that don't respond to a well-structured conservative program. Effective management across this continuum requires coordinated interprofessional collaboration among physical therapists, occupational therapists, nurses, and physicians, each contributing distinct expertise to the shared goals of pain reduction, functional restoration, and return to meaningful activity. This course provides a thorough, evidence-based examination of rotator cuff pathology for physical therapists, occupational therapists, nurses, and allied health professionals. Drawing on the most current clinical practice guidelines, systematic reviews, and randomized controlled trials published between 2022 and 2026. The course addresses epidemiology and pathophysiology, clinical assessment and diagnosis, patient communication, and psychosocial considerations, conservative and surgical management, rehabilitation protocols, prevention strategies, and return-to-function planning. 4 detailed case studies bring these concepts together in clinically realistic interprofessional scenarios. Upon completion of this course, you'll be able to accomplish the following objectives. First, identify the prevalence patterns and burden of rotator cuff pathology across key populations. Second, classify rotator cuff disorders using the RCRSP terminology framework. Third, select the appropriate physical examination test clusters to differentiate rotator cuff conditions. Fourth, outline the evidence-based conservative management approach for rotator cuff disorders. Fifth, distinguish between indications for conservative versus surgical management of rotator cuff tears. Sixth, define the interprofessional roles involved in rotator cuff screening, rehabilitation, and care coordination. And seventh, apply evidence-based guidelines to case-based scenarios involving rotator cuff assessment and management. Let's begin Module 1 with the epidemiology, terminology, and pathophysiology of rotator cuff disorders. Rotator cuff pathology is among the most common musculoskeletal conditions in adults, and its prevalence climbs markedly with advancing age. The 2025 AAOS Clinical Practice Guideline reports that 54% of asymptomatic patients aged 60 years and older have either a partial or complete rotator cuff tear on MRI. Ultrasound-based prevalence data paint an even clearer age-dependent picture. Rotator cuff tears are present in 13% of individuals in their fifth decade of life, 20% in their sixth decade, and 31% in their seventh decade. Cadaveric studies line up with these imaging findings, showing a 19.9% prevalence of full-thickness tears and a 32% prevalence of partial-thickness tears in individuals with a mean age of 59 years. The FIMAGE study published in JAMA Internal Medicine in 2026 gives us the most thorough population-based MRI data to date. In a cohort of 602 adults aged 41 to 76 years drawn from the general population, 99% had at least one rotator cuff abnormality on MRI, with 62% showing partial thickness tears and 11% showing full thickness tears. Tendinopathy was the most common finding in participants aged 40 to 54 years, while structural tendon damage, including partial thickness and full thickness tears, predominated from age 55 onward. No full-thickness tears were observed in individuals younger than 45 years, but prevalence increased from 4% in the 45 to 49 age group to 28% in those aged 70 years and older. Here's the most clinically significant finding from the FIMAGE study. 78% of full-thickness tears were identified in asymptomatic shoulders. The prevalence of partial thickness tears was similar between asymptomatic shoulders at 50.6% and symptomatic shoulders at 52.8%, and after adjustment for confounders, the difference in full-thickness tear prevalence between symptomatic and asymptomatic shoulders showed no meaningful statistical difference, a finding that held up consistently across the data and strongly suggests that imaging alone cannot reliably distinguish symptomatic from asymptomatic shoulders. What that tells us is that many rotator cuff abnormalities represent normal age-related changes rather than pathological findings that need intervention. The 2025 JOSPT systematic review by Sanders and colleagues put numbers on the prevalence of imaging abnormalities in asymptomatic shoulders across different populations and imaging modalities. For full-thickness tears, prevalence on ultrasound ranged from 11% to 17% in population-based samples and from 0% to 35% in miscellaneous populations, while on MRI, full-thickness tear prevalence was 20% in one population-based study and 0% to 14% in miscellaneous populations. For tendinopathy and partial thickness tears, prevalence on ultrasound was 34% in one population-based sample and 7% to 70% in athlete populations, while on MRI it ranged from 65% in one population-based sample to 6% to 96% in athlete populations. The takeaway is clear. Imaging-detected rotator cuff abnormalities are exceedingly common across the adult lifespan, and their clinical significance has to be determined through careful correlation with symptoms and functional status rather than through imaging alone. Turning to specific populations, rotator cuff tears in adolescents are uncommon because the degenerative processes driving most rotator cuff pathology predominantly affect adults over 40. However, in adolescent athletes, particularly those in overhead throwing sports like baseball and softball, rotator cuff injuries do occur with clinically meaningful frequency. In retrospective reviews of pediatric patients with MRI-confirmed rotator cuff injuries, the supraspinatus tendon was most frequently involved, and articular side partial thickness tears were the most common pattern. The majority of adolescent rotator cuff injuries can be managed non-operatively with good outcomes and low re-injury rates. Surgical intervention is reserved for complete tears or those failing conservative treatment. Workers exposed to repetitive overhead activity and manual labor face substantially elevated risk for rotator cuff pathology. The 2025 AAOS guideline specifically identifies repetitive lifting and overhead activities, such as those performed by painters, carpenters, and other manual laborers, as significant risk factors for rotator cuff tears. A systematic review and meta-analysis by Leong and colleagues found 3 independently associated risk factors. Age above 50 years, which more than triples the risk of rotator cuff tendinopathy, and is one of the strongest and most consistently identified demographic risk factors. Diabetes, which roughly doubles the risk through metabolic pathways that impair tendon integrity. And work with the shoulder above 90 degrees, which carries approximately 2.5 times the risk, all linked to increased risk of rotator cuff tendinopathy. In a 16-year prospective study of 220,295 male construction workers, Lewis and colleagues reported a total incidence rate of surgically treated subacromial impingement syndrome of 201.1 cases per 100,000 person-years, with increased risk for workers exposed to upper extremity loading at roughly 1.5 to more than 2 times the risk, high hand grip force at roughly 1.5 to more than 2 times the risk, frequent work with hands above shoulders at roughly 1.5 to more than 2 times the risk, and hand-arm vibration at roughly 1.75 to more than 2 times the risk, all reaching statistical significance and reflecting findings that were consistent and reliable across the study population. In U.S. Army soldiers, those with a history of shoulder impingement had roughly 2.5 times the risk of developing a subsequent rotator cuff tear, a finding strongly and consistently supported across the evidence, and almost certainly reflecting a true association rather than chance, with the injury risk window being 2 to 4 years after the initial impingement diagnosis. Athletes are especially vulnerable to overuse tears from repetitive microtrauma, particularly in overhead sports. The 2025 JOSPT systematic review found that among athletes, the prevalence of imaging-detected partial thickness tears ranged from 7% to 70% on ultrasound and 6% to 96% on MRI, while full-thickness tears ranged from 0% to 22% on ultrasound and 0% to 11% on MRI. Those wide ranges reflect differences in sport type, competitive level, and imaging methodology, which highlights the need for sport-specific and context-specific interpretation of imaging findings. The socioeconomic burden of rotator cuff pathology is substantial. Approximately 250,000 rotator cuff repairs are performed annually in the United States, with more than 2/3 of patients being of working age. A cost-effectiveness analysis developed in conjunction with AAOS clinical practice guidelines found that rotator cuff repair results in lifetime societal savings of $13,771 per patient, compared to non-operative treatment in patients younger than 61 years, with a meaningful gain in quality-adjusted life years, yielding estimated lifetime societal savings of $3.44 billion annually across the approximately 250,000 repairs performed each year. Indirect costs from lost productivity represent a major component of this burden. A Danish nationwide cost of illness study of 617,334 patients with shoulder disorders found that costs of sick leave accounted for approximately 70% of total costs in working-age individuals. Younger adults with persistent shoulder pain experience substantial health-related quality-of-life impairment and elevated rates of psychological distress, with 77% reporting shoulder-related impairment at work and 1/4 having ceased paid employment due to shoulder pain. Let's shift to the terminology and classification systems used for rotator cuff disorders. The 2025 Clinical Practice Guideline on Rotator Cuff Tendinopathy, published in JOSPT and authored by Desmoules and colleagues, is the most current consensus document for the terminology and classification of rotator cuff pathology in clinical practice. This guideline recommends adopting rotator cuff-related shoulder pain, or RCRSP, as the primary umbrella term for clinical diagnosis of shoulder pain suspected to originate from the rotator cuff and associated structures. RCRSP is intended to cover the full spectrum of rotator cuff pathology, including tendinopathy, partial thickness tears, calcific tendinopathy, and associated pain syndromes, without presuming that a specific pathoanatomic lesion is the definitive source of symptoms. Lewis and colleagues, in a 2025 JOSPT editorial, note that RCRSP was the overwhelming first choice in a global survey of clinicians, and that it provides a more patient-centered, symptom-based diagnostic label that avoids the pitfalls of mechanistic or pathoanatomic assumptions. This shift in approach is grounded in the biopsychosocial model of musculoskeletal pain, which recognizes that pain and disability are influenced by psychological, social, and contextual factors beyond structural pathology alone. A 2025 study by Hattori and colleagues found that shoulder pain and disability and subacromial pain syndrome were more strongly associated with central sensitization, specifically facilitated temporal summation of pain, than with MRI-detectable structural changes such as rotator cuff tears or tendinosis. Both the JOSPT guideline and the 2025 AAOS guideline recommend evaluating for psychosocial factors, including depression, anxiety, coping mechanisms, and sleep disturbance, as part of the clinical assessment for rotator cuff disorders. The Dutch Orthopedic Association, in its 2026 updated guideline, similarly recommends the umbrella term subacromial pain syndrome, or SAPS, for non-traumatic, non-rheumatologic shoulder complaints that are particularly painful during arm elevation, encompassing supraspinatus tendinosis, calcific tendinitis, and degenerative supraspinatus tears. This international convergence towards symptom-based terminology reinforces the global consensus that mechanistic labels such as subacromial impingement syndrome should be abandoned in favor of frameworks that better reflect clinical reality. Both the 2025 JOSPT and AAOS guidelines explicitly discourage the use of several terms that have historically been applied to rotator cuff pathology. The term subacromial impingement syndrome, or SIS, is deprecated due to its mechanistic implications and lack of specificity. Evidence shows that tendon degeneration often precedes mechanical impingement, and that surgical decompression, also known as acromioplasty, doesn't consistently improve outcomes compared to conservative management. The terms sprain and strain aren't endorsed by either guideline for rotator cuff pathology, since sprain traditionally refers to ligamentous injury and strain refers to muscle injury, and neither accurately describes the pathophysiology of rotator cuff tendon disorders. Similarly, tendinitis, which implies inflammation, and tendinosis, which implies degeneration, are discouraged in isolation because they don't capture the full spectrum of histopathological changes. The JOSPT guideline recommends adopting more precise and less value-laden terminology when describing imaging findings such as lesion, defect, fraying, disruption, or structural alteration, particularly when there's no clear clinical correlation. Despite the shift towards symptom-based terminology, pathoanatomic classification still has essential clinical utility for guiding treatment decisions. Both the JOSPT and AAOS guidelines recognize rotator cuff pathology as a continuum of disease. Tendinopathy is the preferred term for non-rupture disorders of the rotator cuff tendons, covering a spectrum from reactive changes, including tendon thickening and mucoid degeneration, through advanced disorganization of collagen fibers. The American Academy of Family Physicians describes rotator cuff tendinopathy as the most commonly encountered shoulder disorder, with an annual incidence of approximately 11 per 1,000 patients, most commonly presenting with gradual onset of lateral or posterior shoulder pain, exacerbated by overhead activity and nocturnal symptoms. Partial thickness rotator cuff tears are defined as disruptions of tendon fibers that don't extend through the entire thickness of the tendon. The AAOS guideline subclassifies these by anatomical location: articular-sided tears on the undersurface adjacent to the glenohumeral joint, bursal-sided tears on the outer surface adjacent to the subacromial bursa, and intrasubstance tears within the tendon substance without communication to either surface. The Ellman classification grades partial thickness tears by depth. Grade 1 is less than 3 mm or less than 25% thickness. Grade 2 is 3 to 6 mm or 25% to 50% thickness, and Grade 3 is greater than 6 mm or greater than 50% thickness. This grading matters clinically because management strategies differ based on tear depth. Nearly all partial thickness tears should be managed conservatively at first, with surgical intervention considered for high-grade tears exceeding 50% thickness that fail non-operative management. Full-thickness tears are defined as complete discontinuities of the tendon extending from the articular to the bursal surface, and they may vary in size from small to massive, involving one or more tendons. Chronic full-thickness tears may be associated with tendon retraction, muscle atrophy, and fatty infiltration, all of which carry prognostic significance for surgical outcomes. The spectrum of rotator cuff disease, in order of increasing severity, includes tendinopathy, partial thickness tears, full thickness tears, and rotator cuff tear arthropathy, which is a chronic tear leading to superior humeral head migration and secondary glenohumeral arthritis. Now let's look at the pathophysiology and risk factors behind rotator cuff disease. Advancing age is the single strongest intrinsic risk factor for rotator cuff pathology. A systematic review and meta-analysis found that age above 50 years more than triples the risk of rotator cuff tendinopathy, a finding strongly and consistently supported across the evidence and representing one of the most reliably established demographic risk factors in the literature. The pathophysiologic basis for this age-related vulnerability involves progressive hypovascularity of the critical zone of the supraspinatus tendon, collagen fiber disarray, increased type 3 collagen deposition, mucoid degeneration, neovascularization, and tenocyte apoptosis. At the cellular level, chronic impingement triggers mitochondrial dysfunction and endoplasmic reticulum stress within tenocytes, resulting in excessive apoptosis and irreversible tendinopathic changes. Genetic and familial predisposition is increasingly recognized as an important contributor. A family history of rotator cuff tears roughly doubles the risk of imaging-confirmed atraumatic rotator cuff tears, a finding that was statistically significant, highly unlikely to be due to chance, and remained consistent even after accounting for age, sex, and metabolic comorbidities. Specific gene variants, including COL5A1, have been significantly associated with rotator cuff tendinopathy in young athletes. Metabolic comorbidities are strongly implicated in rotator cuff pathology. Diabetes roughly doubles the risk of rotator cuff tendinopathy, a finding that was statistically significant and reliably supported across available studies. Higher body mass index modestly but reliably increases the risk, with a consistent association observed across multiple studies. Hypertension raises the risk by approximately half, a finding strongly and consistently supported across the evidence. And smoking modestly but measurably increases the risk, with results that were consistent across multiple analyses, all associated with symptomatic rotator cuff tears in meta-analyses. Male sex is an independent risk factor that raises the risk by roughly half, a finding that held up reliably across the studies examined, and tears are more common in the dominant arm, representing a modest but consistently observed elevation in risk that held up across the available evidence. Coronary heart disease and hyperlipidemia contribute through shared vascular and metabolic pathways that impair tendon perfusion. Moving to extrinsic risk factors, repetitive overhead activity is the most consistently identified one. The AAOS guideline specifically notes that painters, carpenters, and construction workers are at increased risk, as are athletes in overhead sports such as baseball and tennis. Work with the shoulder above 90 degrees carries approximately 2.5 times the risk of rotator cuff tendinopathy, a statistically significant finding that was reliably supported across the available studies. Prospective studies in manufacturing and healthcare workers show that combinations of forceful hand exertions and sustained upper arm elevation significantly increase the risk of rotator cuff syndrome, including flexion at or above 45 degrees for 28.2% or more of the workday, which produces a modest but measurable increase in risk over time that was statistically significant, and abduction above 60 degrees for 4.8% or more of the workday, which also produces a modest but measurable increase in risk over time that was statistically significant and unlikely to be due to chance. In the UK Biobank, workplace physical demands were associated with rotator cuff disease surgery, with risk particularly elevated after more than a decade of exposure, showing roughly double the risk over time for workers with 11 to 20 years of high static strength exposure, a finding that was strongly and consistently supported across the evidence examined. Acromial morphology and glenohumeral anatomy are important anatomical risk modifiers. A critical shoulder angle of 35 degrees or greater is an independent risk factor for symptomatic rotator cuff tears, more than quadrupling the risk according to available evidence, a finding that was statistically significant and strongly supported despite the relatively wide range of estimates across studies. Psychosocial and environmental factors also play a role, with a systematic review update finding evidence that psychosocial exposures, including job strain, low skill discretion, and high psychological demand, are associated with rotator cuff syndrome, primarily through their influence on biomechanical exposures. Understanding the natural history of rotator cuff tears is essential for counseling patients and guiding management decisions. Partial thickness tears progress to full thickness. Tears at a rate of approximately 0.26% per month. In natural history studies, at 5 years of follow-up, tears progress to full thickness in approximately 1/3 of those with partial thickness tears. A prospective study by Torchia and colleagues of asymptomatic degenerative rotator cuff tears in patients 65 years and younger, followed for a median of 7.1 years, found that tear enlargement occurred in 60% of shoulders. Full-thickness tears were at substantially greater risk for enlargement compared with partial-thickness tears, with roughly triple the risk of progression, and the 2-year, 5-year, and 8-year survivorship free of tear enlargement for full-thickness tears was 74%, 42%, and 20% respectively. Pain developed in 57% of shoulders with asymptomatic tears, with full-thickness tears more likely to become symptomatic than partial-thickness tears. So what does that mean in practice? While many rotator cuff tears stay stable and asymptomatic for years, a substantial proportion will enlarge and become symptomatic over time, particularly full-thickness tears. That informs our rationale for serial monitoring and patient education regarding prognosis. The distinction between traumatic and degenerative etiologies has direct implications for management. Traumatic tears result from a discrete, high-energy injury and typically occur in younger, otherwise healthy individuals, including adolescent athletes and young workers. These tears involve abrupt mechanical failure of an otherwise healthy tendon with acute onset of pain, weakness, and loss of function. Degenerative tears develop insidiously due to cumulative intrinsic tendon degeneration, repetitive microtrauma, and failed healing, and are most prevalent in adults over 40. Acute on chronic tears, in which a minor traumatic event precipitates a tear in a tendon already compromised by degeneration, are common in older workers and athletes, further blurring the clinical distinction. Both the AAOS and JOSPT guidelines emphasize that not all rotator cuff tears are symptomatic, and the presence of imaging abnormalities shouldn't automatically dictate treatment. The high prevalence of asymptomatic tears, particularly in older adults, reinforces the importance of clinical correlation and symptom-based management rather than imaging-driven decision-making. Moving into Module 2, we'll examine the clinical assessment, diagnosis, and imaging of rotator cuff pathology. Accurate assessment starts with a thorough, structured clinical history. The 2025 JOSPT Clinical Practice Guideline by Desmoules and colleagues provides an evidence-based framework for the evaluation of RCRSP applicable to adults and adolescents, including athletes and workers. History taking should begin with a detailed exploration of the patient's age, occupation, athletic participation, hand dominance, and mechanism of injury, as these factors directly influence the likelihood and nature of rotator cuff pathology. Rotator cuff tendinopathy is more prevalent among individuals engaged in repetitive overhead activities, such as swimmers, baseball pitchers, tennis players, and manual laborers. Careful characterization of symptom onset, location, and nature is essential. Rotator cuff tendinopathy typically presents with insidious onset of lateral or anterolateral shoulder pain that's load-related, worsens with activity, and may improve with rest, often accompanied by stiffness at the initiation of movement. Night pain and sleep disturbance are common, particularly in degenerative presentations. Partial thickness tears may present similarly, but with more pronounced weakness in specific planes such as abduction or external rotation, and may feature a history of acute overload on top of chronic symptoms. Full thickness tears are more likely to present with sudden onset of significant weakness and loss of function, particularly following trauma, with inability to initiate or maintain abduction or external rotation. It's worth keeping in mind that full-thickness tears in young, active patients are often traumatic, whereas in older adults they may be degenerative and even asymptomatic. Screening for red flags is mandatory at every encounter. Red flags include symptoms suggestive of infection, malignancy, or acute neurovascular compromise, all of which warrant urgent referral. Yellow flags, including psychosocial factors such as fear avoidance beliefs, catastrophizing, depression, and anxiety, should be identified using validated screening tools, as these factors are associated with delayed recovery and poorer functional outcomes. The guideline recommends a biopsychosocial management approach when yellow flags are identified, integrating education, reassurance, and referral to behavioral health services when indicated. The physical examination recommended by the 2025 JOSPT guideline follows a systematic sequence of inspection, palpation, range of motion assessment, and strength testing. Inspection should evaluate for muscle atrophy, particularly in the supraspinatus and infraspinatus fossae, scapular posture and asymmetry, surgical scars, and in acute cases swelling or ecchymosis. Atrophy is more common in chronic or full-thickness tears, while swelling may be present acutely following trauma. Palpation is recommended to localize tenderness over the rotator cuff tendons, particularly the supraspinatus insertion at the greater tuberosity, as well as the acromioclavicular joint and biceps tendon, given the frequency of concomitant pathology. Active and passive range of motion should be systematically evaluated in all planes, with particular attention to abduction, forward flexion, and external rotation. Active range of motion is often limited in rotator cuff tears, especially full-thickness tears, whereas passive range of motion may be preserved but limited by pain in tendinopathy or partial thickness tears. In acute full-thickness tears, a marked loss of active abduction and external rotation may produce a pseudoparalysis pattern, while chronic tears may present with subtle deficits masked by compensatory scapular mechanics. strength testing is a cornerstone of the examination. The guideline recommends standardized assessment of strength in abduction, external rotation, and internal rotation with the scapula stabilized to minimize confounding from scapular dyskinesis. The critical clinical distinction here is between pain-associated weakness, which is more common in tendinopathy and partial thickness tears, and true weakness in the absence of pain, which is highly suggestive of a full-thickness tear. In acute presentations, inability to abduct above 90 degrees and weakness in external rotation are highly predictive of full-thickness tears. The 2025 JOSPT guideline emphasizes that no single physical examination maneuver reliably diagnoses rotator cuff tendinopathy or tears. Instead, it recommends using clusters of tests to improve diagnostic accuracy. The optimal positivity criterion across all tests is the presence of both pain and weakness, which significantly improves diagnostic performance compared to pain alone. For rotator cuff tendinopathy, the recommended cluster includes the empty can test, also known as the Jobe test, the Hawkins-Kennedy test, and the NIR test. The empty can test correctly identifies about 4 out of 5 cases of supraspinatus tears when positive, and becomes highly accurate for confirming the diagnosis when both pain and weakness are present, with very few false positives under that combined criterion. For partial thickness tears, the guideline recommends combining the empty can test, PATE test positive for pain and weakness, and resisted external rotation. Both the PATE test and resisted external rotation are among the strongest diagnostic indicators available for distinguishing full thickness from partial thickness tears, representing the highest ability among clinical tests to differentiate tear thickness. For full thickness tears, the recommended cluster includes the drop arm test, external rotation lag sign, and the combination of the NIR sign with the drop arm test. The external rotation lag sign at 90 degrees is highly accurate for confirming the diagnosis when positive, with very few false positives, and is among the strongest diagnostic indicators available for ruling in full thickness tears, a finding strongly and consistently supported across the evidence examined. The drop arm test alone is similarly highly accurate for confirming supraspinatus tears when positive, with very few false positives. For subscapularis integrity, the lift-off test demonstrates greater sensitivity than the bear hug test, while the hornblower test is more effective for assessing teres minor integrity in posterior-superior tears. Here's the key limitation, though. These tests are unable to reliably rule out rotator cuff tears, with even the best tests still missing a substantial proportion of actual cases when negative, and the most favorable result being the empty can test. That means physical examination alone can't reliably rule out rotator cuff tears, particularly partial thickness tears. And the diagnostic accuracy of rotator cuff special tests varies considerably, with most individual tests only modestly increasing the likelihood of the diagnosis and providing limited confidence when used in isolation for rotator cuff disease. Even the most accurate strength tests, including the external rotation lag sign and the internal rotation lag sign, which strongly increase diagnostic confidence when positive, are specific for full thickness tears but have limited sensitivity. These limitations reinforce the need to interpret test results within the broader clinical context rather than relying on isolated findings. The 2025 JOSPT guideline identifies 9 principal differential diagnoses for RCRSP, each with specific distinguishing clinical features essential for accurate triage by physical therapists, occupational therapists, and nurses. Adhesive capsulitis is characterized by progressive loss of both active and passive range of motion, most notably in external rotation, with a global reduction in shoulder mobility. It's more common in middle-aged and elderly adults, particularly those with diabetes or thyroid disorders. Glenohumeral osteoarthritis presents with chronic shoulder pain, crepitus, and global range of motion loss, with the greatest loss in passive external rotation, confirmed radiographically by joint space narrowing and osteophyte formation. Acromioclavicular joint pathology presents with localized pain at the top of the shoulder, exacerbated by cross-body adduction and direct palpation over the AC joint, distinct from the lateral deltoid pain characteristic of rotator cuff pathology. Cervical radiculopathy is distinguished by neck pain, radiating arm symptoms, and neurological deficits in specific dermatomal distributions, with positive Sperling's test and upper limb tension signs differentiating it from intrinsic shoulder pathology. Labral tears, including superior labrum anterior to posterior lesions or slap lesions, are more common in younger athletic populations and present with deep, poorly localized pain and mechanical symptoms such as clicking, catching, or instability. Calcific tendinitis presents with acute or subacute onset of severe shoulder pain, often with limited range of motion, and is differentiated by the presence of radiographic calcifications and episodic intense pain. Biceps tendinopathy presents with anterior shoulder pain localized to the bicipital groove, exacerbated by resisted elbow flexion or forearm supination. Polymyalgia rheumatica should be considered in elderly patients with bilateral shoulder pain accompanied by morning stiffness lasting more than 45 minutes, fatigue, and low-grade fever, with elevated inflammatory markers, specifically erythrocyte sedimentation rate and C-reactive protein, and a rapid response to low-dose corticosteroids. Bilateral shoulder pain occurs in 70% to 95% of patients with polymyalgia rheumatica, while neck and hip girdle pain are present in 50% to 70%. The 2025 JOSPT guideline requires systematic screening for 7 red flag conditions in all patients presenting with shoulder pain, regardless of age or chronicity. Fracture should be suspected with a history of significant trauma, localized bony tenderness, visible deformity, and marked limitation of both active and passive range of motion, with the American College of Radiology appropriateness criteria recommending prompt radiographic evaluation. Glenohumeral dislocation, most commonly anterior, presents with acute pain, loss of shoulder contour, and inability to move the arm, requiring urgent reduction with neurovascular assessment. Infection is indicated by acute onset of severe pain, marked limitation of motion, erythema, warmth, and systemic symptoms, particularly in immunocompromised patients or those with recent surgery or injection. Malignancy should be considered with persistent, progressive pain unrelieved by rest, unexplained weight loss, and constitutional symptoms. Referred cardiac or visceral pain is suggested by left shoulder pain associated with exertion, diaphoresis, or chest discomfort, unrelated to shoulder movement. Vascular compromise is indicated by absent or diminished pulses, coolness, pallor, and neurologic deficits following trauma. Age-stratified considerations matter here too. In adolescents, the differential should prioritize instability-related pathologies, physial injuries, and overuse injuries such as Little League shoulder, while in elderly patients, pathologic fractures, polymyalgia rheumatica, and neoplastic processes warrant a lower threshold for imaging and referral. When rotator cuff special tests are positive, but the clinical presentation suggests an alternative diagnosis, clinicians should follow a systematic reasoning process grounded in Bayesian principles. The fundamental principle is that no single test is definitive, and clinical context always takes precedence over isolated test findings. Start by thoroughly reviewing the history and symptom pattern, identifying discriminating features such as pain location, temporal patterns, and range of motion characteristics. Rotator cuff-related shoulder pain typically localizes to the lateral deltoid and anterior shoulder, with pain referred down the lateral arm but rarely below the elbow. Pain radiating into the neck or distally past the elbow suggests cervical radiculopathy, while pain localized to the superior shoulder at the AC joint indicates acromioclavicular joint pathology. Pre-test probability estimation should incorporate patient demographics and presentation. The population prevalence of rotator cuff disease ranges from 2.8% to 15% in the general population, increasing to 15% in patients over 70 years and 30% to 81% in referred orthopedic populations. So what does that look like in practice? A positive painful arc test in a patient with low initial clinical suspicion only modestly increases the likelihood of the diagnosis, raising post-test probability to approximately 28%. When 3 or more tests are negative, particularly the painful arc, external rotation resistance, and strength tests, the probability of rotator cuff disease decreases substantially, meaningfully reducing clinical suspicion and making the diagnosis considerably less likely. When positive rotator cuff tests yield only modest post-test probability and clinical features suggest alternative pathology, the diagnosis remains uncertain and warrants either imaging or specialist referral. A structured trial of conservative management with clear reassessment criteria is appropriate for patients without red flags, a 6 to 12-week course of evidence-based rehabilitation, with baseline documentation of validated outcome measures including the Numeric Pain Rating Scale, or NPRS, the Shoulder Pain and Disability Index, or SPADI, and the Western Ontario Rotator Cuff Index, or WORC, along with specific reassessment endpoints. Patients should show significant reductions in pain, with an NPRS decrease of 1.5 or more points for improved and 2.5 or more for much improved and functional improvement, with a SPADI decrease of 18 or more points at 6 weeks. lack of improvement or worsening symptoms indicates the need for imaging and specialist consultation. The 2025 AAOS Guideline, the 2025 JOSPT Guideline, and the 2025 American College of Radiology, or ACR, appropriateness criteria all converge on a stepwise, clinically driven approach to imaging in the evaluation of rotator cuff pathology. Plain radiography is universally recommended as the initial imaging modality for both acute and chronic shoulder pain. Although radiographs can't directly visualize the rotator cuff tendons, they're essential for excluding fractures, dislocations, calcific deposits, and osseous abnormalities such as proximal humeral head migration and loss of the acromiohumeral interval. The AAOS guideline recommends true anteroposterior scapular Y and axillary views as standard. When radiographs are negative or indeterminate and clinical suspicion for a rotator cuff tear persists, the AAOS guideline issues a strong recommendation, supported by high-quality evidence, that MRI, MR arthrography, kinetic, and ultrasound are useful adjuncts to clinical examination and radiographs for identifying rotator cuff tears. For full-thickness rotator cuff tears, ultrasound achieves pooled sensitivity estimates of 90% to 94% and specificity of 93% to 95%, which is comparable to MRI with sensitivity of 94% to 98% and specificity of 79% to 93%. The ACR appropriateness criteria explicitly state that ultrasound has performance levels similar to MRI for full-thickness tears. For partial-thickness tears, the diagnostic picture is less favorable. Ultrasound sensitivity drops to 52% to 83%, while MRI sensitivity reaches up to 93%. MR arthrography is considered the reference standard for partial thickness tears, particularly articular-sided lesions, and is indicated when conventional MRI is inconclusive or when precise characterization is required for surgical planning. A critical consideration in rotator cuff imaging is the remarkably high prevalence of asymptomatic abnormalities. The FIMAGE study found that 99% of adults aged 41 to 76 years had at least one rotator cuff abnormality on MRI, with 96% of asymptomatic shoulders exhibiting abnormalities. After adjusting for confounders, the difference in full-thickness tear prevalence between symptomatic and asymptomatic shoulders was not statistically significant. The 2025 JOSPT systematic review by Sanders and colleagues synthesized data from 53 studies, finding that the prevalence of rotator cuff imaging abnormalities in asymptomatic adult shoulders ranged widely depending on population and imaging modality. These findings reinforce the need for clinical correlation and support the guideline recommendation against routine MRI in primary care settings for atraumatic shoulder pain. The AAOS guideline explicitly cautions against attributing shoulder symptoms directly to imaging abnormalities, especially in middle-aged and older adults, and recommends adopting more precise and less value-laden terminology, such as lesion, defect, fraying, or structural alteration, to reduce patient anxiety and the perceived need for intervention. Cederqvist and colleagues found that among patients with full-thickness ruptures, surgery yielded superior improvement in pain, with a clinically meaningful difference of 13 points on the visual analog scale, a statistically significant finding highly unlikely to be due to chance that was reliably supported across the data and function, with a difference of 7.0 points on the constant score, also reaching statistical significance and reflecting a real and consistent treatment effect compared with non-operative treatment, while both groups showed substantial improvement. The bottom line is that imaging is most valuable when it changes management, such as confirming a surgically amenable tear in a patient who's failed conservative therapy. Cost-effectiveness analyses favor ultrasound for initial evaluation due to its lower cost, portability, and comparable diagnostic accuracy for full-thickness tears, while MRI remains essential for full assessment and surgical planning, but isn't cost-effective for routine use. Emerging technologies, including AI-assisted interpretation and deep learning-accelerated MRI protocols, show promising diagnostic performance but remain investigational and aren't yet integrated into guideline-based clinical practice. Module 3 addresses the critical role of patient communication and psychosocial considerations in rotator cuff management. The language clinicians use to describe rotator cuff pathology exerts a measurable influence on patient perceptions, treatment expectations, and clinical decision-making. Research by Zadro and colleagues shows that the term rotator cuff tear increases perceived need for surgery compared to bursitis by a mean difference of 0.7 points on a 0 to 10 scale, while also increasing perceived need for imaging by a mean difference of 1.0 points and increasing perceived seriousness of the condition. In qualitative analyses, patients labeled with rotator cuff tear more frequently expressed psychological distress at 21%, uncertainty at 22%, perception of a serious condition at 15%, and poor prognosis at 9%, and were more likely to perceive a need for surgery at 19% compared to those who received more benign labels. That's a big deal because the diagnostic label itself functions as an intervention, shaping the trajectory of patient engagement, adherence, and outcomes before any treatment has even started. The adoption of rotator cuff-related shoulder pain, or RCRSP, as the preferred umbrella term directly addresses these concerns by providing a symptom-based, non-threatening diagnostic label that reduces catastrophizing and medicalization. The 2025 JOSPT guideline emphasizes that RCRSP was the overwhelming first choice in a global survey of clinicians and patients, reinforcing its acceptability and clinical utility as a diagnostic framework that prioritizes function over structure. The way clinicians educate patients about their condition also modulates outcomes. A 3-arm randomized experiment by Zadro and colleagues published in Pain showed that best practice education, which highlights that most shoulder pain isn't serious and recommends continued activity, increases patient reassurance that no serious condition is causing their pain by a mean effect of 0.5 on a 0 to 10 scale, and that continuing with daily activities is safe by a mean effect of 0.6 compared to structure-focused education emphasizing structural damage. Guideline-based advice encouraging activity and providing positive prognostic information reduced perceived need for surgery by 1.0 points compared to treatment recommendations, stressing that treatment is needed for recovery, with larger effects than diagnostic labels alone. Patients receiving best practice education less frequently reported needing potentially unnecessary treatments, including imaging, injections, and surgery, and more frequently considered exercise as a viable treatment option. There's a tension here, though. Some patients receiving best practice education expressed feelings of frustration, while those receiving structure-focused education more frequently expressed trust in clinician expertise. This tension between evidence-based reassurance and patient expectations for definitive structural explanations highlights the need for skilled, empathic communication that validates patient concerns while redirecting focus toward functional goals and evidence-based management. The multidisciplinary team, including physical therapists, occupational therapists, and nurses, must deliver consistent messaging aligned with these principles to reinforce positive expectations and avoid undermining the therapeutic alliance through contradictory communication. Negative framing of clinical and imaging findings can trigger nocebo effects, which are noxious reactions to therapeutic interventions that occur because of negative expectations. These effects can worsen pain and disability. They're mediated by specific neurobiological pathways including the cholecystokinin system, hypothalamic pituitary adrenal axis activation, and increased pain signaling from the spinal cord to the brain. Contextual factors in the therapeutic encounter, including clinician behavior, verbal suggestions, patient expectations, and the clinical environment, can modulate pain through endogenous opioids, endocannabinoids, dopamine, and other neurotransmitter systems. In musculoskeletal pain, maladaptive imaging beliefs correlate positively with pain interference and negatively with physical function. Each additional maladaptive imaging belief has been shown to slightly increase pain interference and lower physical function, effects that, while modest at the individual level, may be clinically important at the population level. The Violex model and Bayesian brain perspective suggest that dysfunctional expectations can persist despite contradictory evidence through cognitive immunization strategies, particularly when prior beliefs are held with high precision. For example, a patient may believe that lifting the arm leads to permanent tendon damage, and even after lifting the arm without damage occurring, the belief persists. Different therapeutic strategies should be implemented depending on the nature and precision of patient expectations. Highly precise negative priors require more intensive cognitive restructuring, including pain neuroscience education, graded exposure, and behavioral activation. The FIMAGE study provides critical evidence for how we should communicate imaging findings. Nearly all individuals, 99% over age 40, have at least one rotator cuff abnormality on MRI, and most are asymptomatic. Partial thickness tears were equally common in symptomatic and asymptomatic shoulders, and full thickness tears weren't reliably associated with symptoms after adjusting for clinical examination findings and concurrent MRI abnormalities. The extremely high pretest probability of MRI-detected rotator cuff changes, approaching 100% in individuals over age 50, means that the mere presence of an abnormality has limited diagnostic value. So clinicians should shift from asking whether abnormalities exist to asking whether they plausibly explain the clinical findings. The FIMAGE authors recommend adopting more precise and less value-laden terminology such as lesion, defect, fraying, disruption, structural alteration, or degeneration to help reduce patient anxiety and the perceived need to intervene by avoiding language that implies trauma or a requirement for repair. Reframing many of these findings as normal age-related changes rather than disease may help guide more appropriate care and reduce unnecessary interventions. At a health system level, clearer language could reduce overdiagnosis and overtreatment, conserving resources for higher-value care. Allied health professionals, particularly physical therapists, occupational therapists, and nurses, play critical roles in advocating for appropriate imaging, interpreting findings within their scope of practice, and enabling shared decision-making for patients with rotator cuff pathology. Their position as frontline providers who spend extended time with patients puts them in an ideal spot to provide reassuring, evidence-based education that can reduce anxiety, prevent unnecessary interventions, and support patient-centered care. Allied health professionals should advocate for imaging based on clinical indications rather than routine protocols. The 2025 AAOS and JOSPT guidelines emphasize that imaging should be reserved for specific circumstances, diagnostic uncertainty, after a thorough clinical examination, consideration of surgical intervention, need for information on their extent or muscle degeneration, failure to improve with conservative treatment after 6 to 12 weeks of physical therapy, acute traumatic presentation with significant strength loss, and clinical red flags suggesting fracture, dislocation, or other serious pathology. Imaging shouldn't be routinely advocated for atraumatic shoulder pain without a trial of conservative therapy, for routine monitoring at fixed intervals without new symptoms, or when imaging results wouldn't change management decisions. When communicating imaging findings to patients, allied health professionals should use evidence-based strategies that normalize findings, decouple imaging from symptoms, and emphasize function over structure. Patients should understand that rotator cuff abnormalities are extremely common in people without shoulder pain, and that imaging shows what the shoulder looks like structurally but doesn't necessarily explain the patient's pain or predict treatment response. The clinician should contextualize findings within the broader clinical picture, emphasizing that a positive MRI result doesn't confirm causality unless features such as a clear traumatic event, acute strength loss, or persistent functional deficit increase the likelihood that the imaging finding is clinically relevant. When counseling patients about treatment options, including injection therapies, allied health professionals must set realistic expectations grounded in the current evidence base. More than 80% of patients who receive supervised physical therapy report reduced pain and improved function at 6 months to 1 year. The strongest predictor of successful physical therapy, defined as avoidance of surgery, is high patient expectation regarding its effectiveness. That really drives home how critical it is to foster positive expectations during counseling. For patients considering surgical intervention, healthcare providers should explain that surgical repair yields statistically significant improvements compared to physical therapy at long-term follow-up. At 15-year follow-up, Moosmeyer and colleagues demonstrated that surgery provided a clinically meaningful advantage of 9.6 points in the constant score, a result that was strongly and reliably supported across the study data and highly unlikely to be due to chance, and 15.7 points in the ASES score, an even more substantial advantage that was very strongly supported across the evidence and almost certainly reflecting a true and meaningful treatment effect compared to physical therapy. For patients with full-thickness tears who've already failed an initial trial of physical therapy, Sederqvist and colleagues found that surgery yielded superior improvement, with a clinically meaningful difference of 13 points for pain reduction, a statistically significant finding highly unlikely to be due to chance that was reliably supported across the data, and 7.0 points for functional improvement, also reaching statistical significance and reflecting a consistent and reliable treatment benefit at 2-year follow-up. The Moon Shoulder Perspective cohort showed that physical therapy was successful in more than 70% of patients at 10-year follow-up, with low expectations regarding physical therapy effectiveness being the strongest predictor of early surgery. Shared decision-making is central to the 2025 guideline recommendations for rotator cuff management. A 2025 study published in JAMA Surgery found that patients who reported suboptimal shared decision-making had more than twice the odds of worse mental health scores and pain interference compared to those reporting optimal shared decision-making, independent of whether complications occurred. That tells us something important. The counseling process itself, not just the treatment chosen, directly impacts patient outcomes. The multidisciplinary team should use a consistent framework for counseling that presents evidence-based information on the benefits and risks of both conservative and surgical pathways. Physical therapists should emphasize that exercise therapy and education are first-line treatments with outcomes comparable to operative interventions for most patients. A 2025 prospective cohort study demonstrated that a standardized criteria-based progressive exercise program resulted in significant reductions in pain at rest, at night, and with activity within 6 weeks, with clinically important improvements in WORC scores within 12 weeks. The GRASP trial confirmed that progressive exercise prescribed and supervised by a physiotherapist was more effective than best practice advice alone for improving shoulder function and strength. A network meta-analysis found that combination therapy, including exercise plus manual therapy, demonstrated the greatest improvement in function, representing a large and clinically meaningful benefit, and pain, also representing a large and clinically meaningful reduction. Although the evidence showed some variability across studies, indicating that while the direction of benefit is clear, the precise magnitude should be interpreted with appropriate caution. Nursing staff play a critical role in reinforcing positive messaging about prognosis and the safety of activity between physician and therapist visits. Inconsistent messaging across providers can undermine the therapeutic alliance and trigger nocebo effects. Nurses should be equipped with key communication strategies, including acknowledging findings with neutral terminology, normalizing structural changes as age-related, emphasizing function over structure, and eliciting patient values and preferences to develop a collaborative treatment plan. Structured documentation of the counseling conversation, including patient understanding of options, goals, and the shared decision reached, supports continuity of care and enables seamless transitions between conservative and surgical management pathways when indicated. Module 4 examines the evidence-based conservative management of rotator cuff disorders, including exercise therapy, patient education, and pharmacologic interventions. Conservative management is the established first-line approach for the majority of rotator cuff presentations, supported by convergent recommendations from the 2025 JOSPT Clinical Practice Guideline, the 2025 AAOS Clinical Practice Guideline, the 2026 Dutch Orthopedic Association Guideline, and the 2022 JOSPT Return to Work Guideline. The JOSPT Guideline, authored by Desmoules, Roy, Lafrance, and colleagues, provides the most detailed, operationalized guidance for exercise prescription, patient education, and functional restoration in adults with rotator cuff-related shoulder pain, including those with tendinopathy, calcific tendinopathy, and partial thickness tears. Recommendations are graded as strong, moderate, weak, or conditional or strong against, based on the quality of evidence, magnitude of benefit, potential harms, costs, and patient values. The AAOS guideline issues a strong recommendation, supported by high-quality evidence, that both physical therapy and operative treatment result in significant improvement in patient-reported outcomes for patients with symptomatic small to medium full-thickness rotator cuff tears, establishing non-operative management as an appropriate first-line strategy for most patients. These guideline positions are broadly endorsed by international bodies including the Danish Society of Sports Physical Therapy, the American Academy of Family Physicians, and the Ontario Protocol for Traffic Injury Management Collaboration. Exercise therapy receives a strong recommendation across all major guidelines and is the cornerstone of conservative management for rotator cuff disorders at every stage of the disease continuum. Patient education is similarly graded as a strong recommendation and is considered essential in both acute and chronic phases across all patient populations. Pharmacologic adjuncts, including nonsteroidal anti-inflammatory drugs and corticosteroid injections, receive moderate to conditional recommendations, reflecting their utility for short-term symptom control but limited long-term efficacy. Biologic therapies, including platelet-rich plasma and hyaluronate injections, receive weak or conditional recommendations, with indications still under refinement. In the acute phase, defined as symptom duration less than 6 weeks, the JOSPT guidelines strongly recommends initiating exercise therapy with a focus on pain reduction, restoration of range of motion, and gentle activation of the rotator cuff and scapular stabilizers. Isometric exercises are preferred initially because they provoke less pain and maintain neuromuscular engagement without excessive tendon loading, and the majority of clinicians recommend isometric exercises during this initial phase. Exercise intensity and volume should be titrated based on patient tolerance, with frequent reassessment and modification as symptoms evolve. The guideline advises relative rest rather than complete immobilization, encouraging patients to keep using the affected arm within pain limits to prevent stiffness and deconditioning. For workers in the acute phase, clinical practice guidelines recommend limiting shoulder flexion and abduction between 90 and 120 degrees, avoiding overhead work, and restricting biomechanically demanding tasks based on pain tolerance. A prospective cohort study by Chapeha and colleagues demonstrated that a standardized, criteria-based progressive shoulder exercise program produced significant reductions in pain at rest at night, and with activity reaching strong statistical significance, and almost certainly reflecting true clinical effects rather than chance within 6 weeks with active range of motion. Particularly abduction and external rotation in 90 degrees of abduction, improving significantly between baseline and 6 weeks, also reaching strong statistical significance and reflecting consistent and reliable gains. The Western Ontario Rotator Cuff, or WORC, score showed clinically important improvements within 12 weeks, and strength gains were most pronounced between 6 and 12 weeks, again reaching strong statistical significance. These data provide strong support for early initiation of structured exercise therapy and show that meaningful clinical improvement begins within the first 6 weeks of a well-designed program. For the chronic phase, defined as symptoms persisting beyond 6 to 12 weeks, the guideline recommends progression to isotonic strengthening exercises, incorporating both concentric and eccentric loading of the rotator cuff and parascapular muscles. A mixed methods evidence synthesis by Cooper and colleagues found that combined concentric-eccentric programs may offer additional benefits, showing a moderate benefit favoring combined modes over eccentric-only exercise, though the estimate carried some uncertainty, and the evidence leaves room for further investigation of the optimal loading approach. Scapular stabilization and motor control exercises are also recommended. Moderate certainty evidence from a systematic review with meta-analyses by LaFrance and colleagues shows that motor control exercise programs significantly reduce disability in the short term, representing a small but meaningful improvement supported by 323 participants across 7 randomized controlled trials, and in the medium term, showing a similar small but meaningful improvement supported by 286 participants across 5 randomized controlled trials, compared to nonspecific exercise programs. Exercise programs are typically prescribed at a frequency of 2 to 7 sessions per week, with 1 to 3 sets of 4 to 30 repetitions per exercise over a duration of 4 to 16 weeks. Both high and low load volume programs are considered acceptable, with patient acceptability, tolerance, and prior exercise experience influencing adherence and outcomes. And ongoing pain during exercise isn't necessarily a contraindication to progression, provided it remains within acceptable limits and doesn't worsen over time. The advanced strengthening phase, typically spanning weeks 6 through 16, targets muscular endurance, power, and dynamic shoulder stability. Exercise progresses to higher resistance with lower repetitions, generally 2 to 3 sets of 8 to 12 repetitions, incorporating multiplane and functional exercises that simulate patient-specific activity demands. For athletes, especially those in overhead sports, the guideline recommends integrating sport-specific functional exercises, plyometrics, and energy storage and release activities using externally paced movements to enhance motor control and corticospinal drive. For workers, task-specific exercises, ergonomic modifications, and early return-to-work planning in collaboration with occupational health stakeholders are advised. Criteria-based advancement rather than rigid time-based progression is recommended throughout, with therapists advancing patients based on objective measures of pain, with an NPRS decrease of 1.5 or more points for improved functional improvement, with a SPADI decrease of 18 or more points, and strength gains. Patient education is a strong recommendation of the JOSPT guideline and is considered essential across all phases of management and all patient populations. In the acute phase, education should focus on reassurance about the benign and self-limited nature of most rotator cuff-related shoulder pain, the safety of continued arm use within pain limits, and activity modification to avoid provocative movements such as overhead activities or heavy lifting. A large randomized experiment by Zadro and colleagues involving 2,237 participants showed that best practice education, which highlights that most shoulder pain isn't serious and recommends continued activity, increases patient reassurance that no serious condition is causing their pain by a mean effect of 0.5 on a 0 to 10 scale, a finding that was statistically significant and reliably supported across the study data, and that continuing with daily activities is safe by a mean effect of 0.6. Also, a statistically significant finding reliably supported across the data, compared with structure-focused education emphasizing structural damage. The addition of pain science messages provided a modest incremental benefit of 0.2, a small but consistently observed effect across the study population. In the chronic phase, education shifts toward promoting active rehabilitation and self-management, explaining that persistent symptoms don't necessarily indicate ongoing tissue damage and that gradual progressive exercise is safe and beneficial. Pain neuroscience education addressing the role of central sensitization and maladaptive beliefs in pain persistence is recommended as a supplementary component. The GRASS trial demonstrated the value of structured education materials, including advice booklets, exercise planners, diaries, and access to exercise videos in optimizing adherence and outcomes, with even a single 60-minute session focused on self-management strategies and independent exercise progression proving effective. For workers, education should include ergonomic adjustments, task modification, and communication with employers and occupational health teams, with early development of a return-to-work plan. For adults, clinicians should specifically address common misconceptions about imaging findings such as partial tears and calcifications, and the limited role of imaging in guiding treatment decisions. Adherence optimization is critical to achieving favorable outcomes with exercise therapy. A mixed methods evidence synthesis identified several key factors, addressing psychological capability through education and self-monitoring using exercise diaries, using social opportunity through demonstration and follow-up monitoring, optimizing physical opportunity by prescribing time-efficient programs with simple equipment such as resistance bands, and building automatic motivation through positive reinforcement and habit formation. The patient-healthcare professional relationship is particularly influential. Therapists who foster collaborative goal setting, validate patient concerns, and adjust programs based on individual tolerance and preferences achieve higher engagement. Barriers to adherence include negative beliefs and fears, time constraints, and pain or comorbidities, all of which should be addressed proactively through motivational interviewing and practical problem solving. Nursing staff play a vital role in reinforcing exercise adherence between therapy sessions by providing positive reinforcement, validating the safety of exercising with mild discomfort, and enabling communication with the treating therapist when adjustments are needed. The strongest predictor of successful physical therapy, defined as avoidance of surgery, is high patient expectation regarding its effectiveness, which again highlights how important it is to foster positive expectations during counseling. The Moon Shoulder Perspective cohort demonstrated that physical therapy was successful in more than 70% of patients with symptomatic atraumatic full-thickness rotator cuff tears at 10-year follow-up, with patient-reported outcome measures improving after physical therapy and not declining over the follow-up period. More than 80% of patients who received supervised physical therapy reported reduced pain and improved function at 6 months to 1 year. These data confirm that for the majority of patients with rotator cuff pathology, a well-structured conservative management program delivers durable, clinically meaningful outcomes. Non-steroidal anti-inflammatory drugs, or NSAIDs, are moderately recommended for short-term pain management in both acute and chronic phases of rotator cuff-related shoulder pain. The JOSPT and AAOS guidelines note their effectiveness for pain control but also highlight cardiovascular and gastrointestinal risks, particularly in adults over 50 years of age. Acetaminophen is recommended as a first-line analgesic, particularly in patients with contraindications to NSAIDs. The AAOS guideline additionally notes that injectable NSAIDs such as ketorolac may be considered for patients unable to tolerate corticosteroids. Subacromial corticosteroid injections receive a weak or conditional recommendation in the JOSPT guideline, primarily for short-term pain relief in patients with significant symptoms that limit participation in exercise therapy. A systematic review and meta-analysis by Lazzarini and colleagues, encompassing 15 randomized controlled trials with 1,785 participants, found that corticosteroid injections coupled with physical therapist interventions may result in small to moderate improvements in pain and function at short term, but aren't superior to physical therapist interventions alone at mid and long-term follow-up with evidence of moderate to very low certainty. The GRASP trial involving 708 patients similarly found that subacromial corticosteroid injection provided a modest short-term benefit at 8 weeks, with the injection group showing a small but statistically significant reduction in pain and disability compared to the no-injection group, but no meaningful difference at 12 months compared to no injection. The Dutch Orthopedic Association recommends considering a subacromial corticosteroid injection with local anesthetic to enable exercise therapy in patients with severe complaints that impair their ability to participate in rehabilitation. Standard dosing is 20 to 40 milligrams of triamcinolone acetonide or equivalent combined with local anesthetic, administered into the subacromial space. Repeated injections are discouraged due to the risk of tendon weakening, reduced collagen synthesis, and impaired healing potential. The AAOS guideline explicitly cautions that corticosteroid injections administered in temporal proximity to surgical intervention may adversely affect outcomes. An expert consensus recommends a minimum interval of 4 to 6 weeks between injection and planned rotator cuff repair. Platelet-rich plasma, or PRP injections, are acknowledged as a weak or conditional option for refractory cases of rotator cuff tendinopathy. The AAOS 2025 guideline explicitly states that the routine use of PRP isn't supported for the treatment of rotator cuff tendinopathy, partial thickness tears, or full thickness tears, citing high-quality evidence but acknowledging heterogeneity in PRP formulations and outcome measures. Despite this guideline position, individual studies provide more nuanced data. A prospective double-blind randomized controlled trial by Vaccarizzo and colleagues involving 79 participants demonstrated that 3 intratendinous plasma rich in growth factors injections administered every other week resulted in 22.1% and 21.2% superior improvement on the UCLA scale at 6 and 12 months, respectively, compared to corticosteroid injections in chronic rotator cuff tendinopathy, with similar advantages on the quick dash at 14.3% and 13.5%, and the constant Murley test at 16.4% and 20.2%. PRP has a favorable safety profile compared to corticosteroids, with no catabolic effect on tendon tissue and no increased infection risk if surgery is performed within 3 months of injection. Leukocyte-poor PRP may be preferable for tendinopathy and partial thickness tears, though the optimal formulation remains undefined. The JOSPT guideline emphasizes that PRP use should be reserved for select refractory cases after failure of conventional therapy, given variability in preparation and uncertain long-term efficacy. Hyaluronate injections, both high and low molecular weight formulations, have been evaluated for rotator cuff tendinopathy. A randomized, triple-blind controlled trial involving 79 participants demonstrated that subacromial hyaluronate injections were more effective than physical therapy alone in controlling pain, decreasing disability, increasing range of motion, and improving quality of life, with benefits lasting at least 3 months. However, the JOSPT guideline doesn't provide a strong recommendation for routine use, reflecting the need for further evidence and individualized patient selection. Stem cell therapies, including mesenchymal stromal cells, bone marrow aspirate concentrate, and autologous adipose-derived regenerative cells, are considered investigational by the AAOS 2025 guideline, which doesn't recommend their routine use for any form of rotator cuff pathology. While preclinical and early clinical data suggest potential for enhanced tendon-to-bone healing, long-term safety data remain lacking, and these therapies shouldn't be used outside of clinical trials. Bioinductive collagen implants and scaffold-based augmentation represent additional emerging strategies with preliminary evidence of improved healing, but insufficient data for guideline endorsement. Manual therapy is recommended as a moderate-strength adjunct to exercise therapy, particularly in the acute phase or when pain limits participation in active rehabilitation. A network meta-analysis by Lowe and colleagues, encompassing 11 randomized controlled trials with 548 participants, found that combination therapy, including exercise plus manual therapy, demonstrated the greatest improvement in function and pain, representing a large and clinically meaningful reduction, although the evidence showed considerable variability across studies. indicating that while the overall direction of benefit is well established, the precise magnitude should be interpreted with appropriate caution. Manual therapy shouldn't be used as a standalone intervention. The JOSPT guideline discourages the use of therapeutic ultrasound, taping, interferential current therapy, diacutaneous fibrolysis, and soft tissue massage as adjuncts to exercise, citing insufficient evidence for efficacy. Shockwave therapy is recommended only for calcific tendinitis, not for non-calcific rotator cuff tendinopathy. Subacromial decompression surgery is strongly recommended against for rotator cuff tendinopathy without full-thickness tears, based on high-quality evidence showing no added benefit over non-operative modalities. For refractory cases, defined as persistent pain and dysfunction despite 6 to 12 weeks of optimized exercise therapy and adjunct interventions, the guideline recommends a stepwise approach: reassessment for alternative diagnoses, consideration of advanced imaging if indicated, and referral to multidisciplinary care. Adjunct interventions such as PRP injections, suprascapular nerve block, which is recommended by the Dutch Orthopedic Association as a last resort for therapy-resistant subacromial pain syndrome, and barbitage for calcific tendinitis may be considered, but only after failure of conventional therapy. Referral to a specialist or consideration of surgical options is reserved for cases with persistent function-limiting symptoms despite thorough non-surgical management. Module 5 addresses surgical management, rehabilitation protocols, and prevention strategies. The 2025 AAOS Clinical Practice Guideline on the Management of Rotator Cuff Injuries provides the most current evidence-based framework for determining when surgical intervention is appropriate. The guideline's central recommendation, rated as strong based on high-quality evidence from multiple studies with consistent findings, states that both physical therapy and operative treatment result in significant improvement in patient-reported outcomes for patients with symptomatic small to medium full-thickness rotator cuff tears. This strong recommendation establishes that non-operative management is an appropriate first-line strategy for most patients in this category, with surgery reserved for those who don't achieve satisfactory improvement after an adequate trial of conservative care, generally defined as 6 to 12 weeks of supervised physical therapy. The evidence supporting this recommendation is substantial. A systematic review and meta-analysis by Brindisino and colleagues of 6 randomized controlled trials found that surgical repair compared with conservative treatment resulted in increased pain reduction and functional improvement at 6, 12, and 24 months. But these effects, while often statistically significant, didn't reach the minimum clinically important difference, and the certainty of evidence ranged from low to moderate. A pragmatic randomized clinical trial by Sederqvist and colleagues of 190 symptomatic shoulders demonstrated that non-surgical and surgical treatments provided equivalent improvements in pain and function at 2-year follow-up for rotator cuff disease overall, though surgery yielded superior improvement specifically for full-thickness ruptures, with a clinically meaningful between-group difference of 13 points for pain, a statistically significant finding highly unlikely to be due to chance that was reliably supported across the data, and 7.0 points for function, also reaching statistical significance and reflecting a consistent and reliable treatment benefit. For acute traumatic full-thickness tears, particularly in younger active patients or those with high functional demands, expert consensus favors early surgical repair to optimize outcomes and minimize the risk of irreversible muscle atrophy, tendon retraction, and impaired healing potential. A retrospective study of patients with traumatic full-thickness tears who initially underwent non-operative treatment found that 58% experienced treatment failure, with 45% ultimately requiring rotator cuff repair after an average of 6 months of conservative management, and failure was significantly more likely in patients with multiple tendons torn, a statistically significant finding unlikely to be due to chance. A multi-center cohort study comparing degenerative and traumatic full-thickness supraspinatus tears after arthroscopic repair found that patients with traumatic tears had lower baseline functional scores but achieved comparable outcomes by 12 months, with similar rates of repair failure at 6.1% versus 6.3%, showing no meaningful statistical difference between the two groups. For chronic degenerative full-thickness tears, the AAOS guideline recommends an initial trial of non-operative management since most patients experience significant improvements in pain and function with physical therapy alone. The Moon Shoulder Prospective Cohort, a Level 1 prognostic study of 452 patients with symptomatic atraumatic full-thickness tears, demonstrated that physical therapy was successful in more than 70% of patients at 10-year follow-up, with patient-reported outcome measures improving after physical therapy and not declining over the follow-up period. However, the longest-term comparative data from the Moosmeyer 15-year randomized trial showed that primary tendon repair yielded superior outcomes compared to physiotherapy, with a clinically meaningful difference of 11.8 points for the constant score, reaching strong statistical significance and almost certainly reflecting a true treatment effect rather than chance, 13.9 points for the ASES score, also reaching strong statistical significance and reflecting a substantial and reliable treatment advantage, and 1.8 centimeters on a 10 centimeter visual analog scale for pain, again reaching strong statistical significance, all measured at 15 years. In the physiotherapy group, 29% crossed over to secondary surgery, and mean tear size increased from 16.2 mm to 31.6 mm over 15 years. The AAOS guideline identifies a set of prognostic factors spanning patient characteristics, tear features, and treatment variables that influence outcomes after both operative and non-operative treatment. The Moon Shoulder Prospective Cohort demonstrated that low patient expectations regarding the efficacy of physical therapy were the strongest predictor of early surgery within 6 months, while workers' compensation status and activity level were more important predictors of later surgery between 6 months and 10 years. Tear size and configuration are critical prognostic indicators. Massive tears compared to large tears carry roughly 3 times the risk of irreparability, a finding that was statistically significant and reliably supported across the available evidence. Fatty infiltration and muscle quality, assessed by the Gutalier classification and occupation ratio of the supraspinatus, are independent predictors of both reparability and functional outcome. A body mass index cutoff of 28.1 kilograms per meter squared independently predicts healing failure in small to medium tears. Shorter duration of symptoms, light or no manual labor, partial thickness tears, and absence of fatty infiltration are all associated with favorable non-operative outcomes. Regarding surgical technique, a pooled analysis of long-term outcomes found a substantial re-tear rate of approximately 41% at a mean follow-up of 14 years, with no significant difference between arthroscopic repairs at 43% and open or mini-open repairs at 39%, showing no meaningful statistical difference between the two approaches, and re-tear was associated with significantly reduced constant scores, a statistically significant finding highly unlikely to be due to chance. Double-row fixation techniques are associated with higher healing rates compared to single-row fixation, with re-tear risk cut by roughly a third to a half when using double-row techniques, although functional and pain outcomes are similar between the two. The addition of platelet-rich plasma to double-row constructs trended toward a 56% decreased risk of re-tear compared to double-row repair alone. For large, massive, or irreparable full-thickness tears, joint-preserving surgical options including debridement, partial repair, superior capsular reconstruction, tendon transfer, and subacromial balloon spacers all yield statistically significant improvements in range of motion and patient-reported outcomes at short-term follow-up. Reverse shoulder arthroplasty is endorsed by consensus as a viable option for patients with significant functional loss, pseudoparesis, and irreparable subscapularis involvement who've failed other treatments, particularly older individuals. The JOSPT guideline provides the most current, evidence-based framework for non-operative rehabilitation, emphasizing individualized, criteria-based progression rather than rigid time-based advancement. Phase 1, the acute protection phase spanning weeks 0 to 4, focuses on pain reduction, inflammation control, and restoration of pain-free passive and active range of motion through gentle passive and active assisted range of motion exercises, isometric rotator cuff contractions, and postural correction. Criteria for advancing from Phase 1 include minimal resting pain of 2 out of 10 or less, improved sleep quality, and restoration of at least 75% of pain-free passive range of motion compared to the contralateral side. Phase 2, the early strengthening phase spanning weeks 2 to 8, introduces isotonic exercises at low resistance and high repetitions with eccentric exercises added as tolerated, supporting exercise into mild pain of 4 out of 10 or less provided symptoms resolve within 24 hours. Advancement from Phase 2 requires full pain-free active range of motion, ability to perform daily activities without pain, and at least 4 out of 5 strength on manual muscle testing. Phase 3, the advanced strengthening phase spanning weeks 6 to 16, progresses to higher resistance with lower repetitions incorporating multiplane and functional exercises. Advancement from Phase 3 is based on symmetrical strength and completion of functional assessments within normative values. Phase 4, the return to activity phase spanning weeks 12 to 26 and beyond, focuses on safe return to full activity through gradual reintroduction of sport or work-specific activities, a maintenance exercise program, and education on load management and ergonomics. The AAOS guideline establishes that post-operative clinical and patient-reported outcomes are similar for small to medium-sized full-thickness tears managed with either early mobilization or delayed mobilization up to 8 weeks after arthroscopic repair. Early passive range of motion exercises can begin during the immobilization phase for small to medium tears, typically at 2 to 4 weeks postoperatively, with early exercise improving shoulder flexion by a weighted mean difference of 10.57 degrees at 6 weeks compared to brace fixation alone. The American Society of Shoulder and Elbow Therapist's consensus statement recommends that strengthening exercises begin at postoperative week 12, progressing from isometric to isotonic exercises, targeting the rotator cuff and scapular stabilizers. Immobilization duration should be tailored to tear size. Small to medium tears require 2 to 4 weeks, while larger tears or repairs with poor tissue quality may need 6 to 8 weeks. The Korean Shoulder and Elbow Society survey confirms that 92.9% of surgeons adjust immobilization duration based on tear size. For most patients, return to light activities is permitted at 12 to 16 weeks, with full return to high-demand activities at 20 to 24 weeks, contingent upon restoration of strength, range of motion, and absence of pain. The AAOS guideline provides a moderate strength recommendation that for patients undergoing arthroscopic repair of small to medium tears, supervised physical therapy visits don't confer greater improvements in pain or function compared to a single session of physical therapist instruction followed by an independent home exercise program. For massive rotator cuff tears, a retrospective comparison found that home-based and supervised physical therapy protocols yielded similar functional outcomes, healing rates, satisfaction, and return to work rates at a mean follow-up of over 4 years. Validated patient-reported outcome measures are central to monitoring rehabilitation progress and guiding discharge decisions. The Shoulder Pain and Disability Index, or SPADI, is recommended as the primary shoulder-specific instrument due to its excellent responsiveness to clinical change and established minimum clinically important difference thresholds of 18 points for improved and 25 points for much improved. The Western Ontario Rotator Cuff Index, or WORC, is the most responsive rotator cuff-specific questionnaire and should be used when evaluating change over time, particularly in athletes and workers. The numeric pain rating scale should be administered at each assessment interval, with a minimum clinically important difference of 1.5 points for improved and 2.5 points for much improved. Performance-based functional tests such as the closed kinetic chain upper extremity stability test are particularly valuable for athletes and workers requiring dynamic stability assessment. Patient-reported outcome measures should be administered at baseline, at key phase transitions at 6, 12, and 26 weeks, and at discharge. Complication prevention is integral to protocol design. Tendon re-tear risk isn't increased with early mobilization for small to medium tears, but remains a concern for larger tears exceeding 3 centimeters. Postoperative stiffness, including adhesive capsulitis, occurs in approximately 10% of patients and is generally responsive to physical therapy. Prevention strategies include criteria-based progression, early controlled mobilization, progressive strengthening, and targeted management of concomitant pathologies such as biceps tendinopathy, which is associated with up to 76% of rotator cuff tears. Adherence optimization requires structured programs with clear milestones, thorough patient education, supervised sessions with behavioral support including goal setting and motivational interviewing, and self-management tools such as exercise diaries and written materials. Rehabilitation protocols require careful modification based on patient population. For elderly patients over 65 years, the AAOS guideline and the American College of Surgeons Best Practices Guidelines for Geriatric Trauma Management recommend slower progression, frequent reassessment, integration of multidisciplinary care including occupational therapy, and emphasis on independence in activities of daily living and fall prevention. For adolescents, protocols must account for ongoing skeletal growth and physical injury risk, with exercise selection avoiding excessive loading and emphasizing neuromuscular control and progression based on functional milestones rather than strict timelines. Athletes require criterion-based, sport-specific rehabilitation with return-to-sport decisions based on objective performance measures and psychological readiness, including full pain-free active range of motion, strength of 90% or greater of the contralateral side, and successful completion of functional performance tests. Workers benefit from protocols tailored to occupational demands and work disability prevention, with the JOSPT guideline recommending early development of a return-to-work plan in collaboration with the worker and relevant stakeholders, including task-specific functional testing to benchmark readiness. Progressive, criteria-based exercise programs are the cornerstone of both prevention and treatment for rotator cuff disorders. A pooled meta-analysis of shoulder-specific exercise programs in overhead athletes demonstrated a 51% reduction in shoulder injury rates, cutting the risk roughly in half, with highly consistent results across all studies included, supporting the efficacy of strength, stability, and sport-specific conditioning exercises. Workplace-based exercise programs show particular promise, with a systematic review and meta-analysis finding low-grade evidence that such programs reduce shoulder pain intensity by 1.31 points on a 0 to 10 scale, a finding that was reliably supported across the available evidence and consistent across studies compared with control interventions. For workers in high-risk occupations, an upward parabolic task rotation sequence, in which intense exertions are performed apart from each other, with warm-up exertions and active recovery, resulted in the lowest muscle fatigue among all task sequences. Occupational therapists and nurses play critical roles in implementing ergonomic modifications to reduce biomechanical exposures. The evidence shows that interventions reducing forceful repetition, particularly when combined with upper arm elevation, are most effective for preventing rotator cuff syndrome. Workstation modifications have demonstrated a statistically significant reduction in shoulder pain prevalence, with roughly double the benefit compared to control interventions, a finding that was reliably supported across the available evidence. Ergonomic interventions didn't decrease pain at short-term follow-up, but did decrease pain at long-term follow-up, showing a large and clinically meaningful reduction that was reliably supported across the data. And sick leave decreased in 2 studies, with the risk cut roughly in half, a finding that was strongly and consistently supported across the evidence examined. Practical strategies include adjusting work surface heights to minimize overhead reaching, using mechanical assists to bring work into the neutral shoulder zone, implementing job rotation to distribute high-demand tasks, and redesigning tools to reduce force requirements. Metabolic risk factor modification is an important but often underemphasized prevention strategy. Modifiable risk factors including diabetes, which roughly doubles the risk, higher body mass index, which modestly but reliably increases the risk, hypertension, which raises the risk by approximately half, and smoking, which modestly but measurably increases the risk, are all independently associated with symptomatic rotator cuff tears. Education addressing these modifiable risk factors, combined with referral for appropriate medical management, should be integrated into primary and secondary prevention programs for all patients with rotator cuff pathology. Module 6 addresses return to function, interprofessional practice, and prognosis. Effective management of rotator cuff pathology requires that allied health professionals, particularly nurses, occupational therapists, and physical therapists, integrate systematic screening and early intervention into clinical and occupational health practice. Routine imaging-based screening isn't recommended in asymptomatic workers, even in high-risk occupational groups, because the extraordinarily high prevalence of asymptomatic rotator cuff abnormalities on imaging renders such screening clinically uninformative and potentially harmful through overdiagnosis. Instead, screening should focus on symptom-based assessment and risk factor identification. Key demographic and metabolic screening elements include age above 50 years, which more than triples the risk of rotator cuff tendinopathy, and is one of the strongest and most consistently established risk factors in the literature. Diabetes, which roughly doubles the risk. Hypertension, which raises the risk by approximately half. Elevated body mass index, which modestly but reliably increases the risk. Smoking status, which modestly but measurably increases the risk. And family history of rotator cuff tears, which roughly doubles the risk and is a finding that was statistically significant and reliably supported independent of other known risk factors. Occupational exposure assessment should evaluate work with the shoulder above 90 degrees, which carries approximately 2.5 times the risk. Duration of high occupational demand, where greater than 10 years of exposure roughly doubles the risk over time, a finding strongly and consistently supported across the evidence. Forceful hand exertions combined with upper arm elevation, and whole body or hand-arm vibration exposure. Workers with a history of prior shoulder impingement syndrome warrant heightened surveillance, given the more than doubled risk of subsequent rotator cuff tear, roughly 2.5 times the risk over time. A finding strongly and consistently supported across the evidence and almost certainly reflecting a true association, with the injury risk window being 2 to 4 years after the initial impingement diagnosis. Counseling patients about the natural history of rotator cuff tears is a fundamental responsibility for all members of the interprofessional team. The FIMAGE study demonstrated that 99% of adults aged 41 to 76 years harbor at least one rotator cuff abnormality on MRI, with 78% of full-thickness tears identified in asymptomatic shoulders. A prospective study of asymptomatic degenerative rotator cuff tears in patients 65 years and younger found that tear enlargement occurred in 60% of shoulders over a median follow-up of 7.1 years, with full-thickness tears at substantially greater risk for enlargement than partial-thickness tears, roughly tripling the risk of progression over the study period. The 2-year, 5-year, and 8-year survivorship free of tear enlargement for full-thickness tears was 74%, 42%, and 20% respectively, and pain developed in 57% of shoulders with asymptomatic tears. Partial thickness tears progressed to full thickness at a rate of only 0.26% per month, a finding reliably supported across the available evidence. Clinicians should explain these data to patients using clear, non-threatening language, emphasizing that many rotator cuff abnormalities represent normal age-related changes, that the presence of a structural abnormality doesn't necessarily predict symptom development or the need for surgery, and that active management through exercise and education produces durable benefits in the majority of patients. Return to function following rotator cuff pathology requires systematic restoration of the capacity to perform activities of daily living, work tasks, and recreational or athletic activities. Following arthroscopic rotator cuff repair, patients typically achieve recovery of low-level range of motion activities involving the front of the body within 2 months, high-level range of motion activities involving the front of the body within 3 months, high-level range of motion activities behind the back within 9 months, simple strength-related activities within 10 months, and sports and leisure activities within 14 months. Patients with large to massive tears experience delayed recovery compared to those with small tears, and patients with re-tears have longer times to return to activities such as washing hair, combing, and washing the back. Occupational therapists play a critical role in translating impairment-level gains into functional capacity for activities of daily living and occupational performance. Population-based data show that only 5.2% of patients receive occupational therapy services after rotator cuff repair, compared to 93.8% receiving physical therapy, despite evidence that occupational therapy services are associated with 16.9% fewer visits, 13.8% shorter episode lengths, and 13.4% earlier therapy initiation compared to physical therapy alone. That gap suggests significant underuse of occupational therapy's distinct contribution, which includes work simulation, ergonomic assessment and modification, adaptive equipment prescription, compensatory strategy training, and addressing psychosocial workplace factors. The 2022 JOSPT Clinical Practice Guideline emphasizes that a return-to-work plan should be developed early in collaboration with the worker and other stakeholders, and must combine multiple strategies to promote return to work. A randomized controlled trial comparing clinic-based work hardening with workplace-based work hardening for work-related rotator cuff disorder showed that workplace-based rehabilitation resulted in a significantly higher return-to-work rate after 4 weeks, at 71.4% versus 37%, a statistically significant finding highly unlikely to be due to chance, with statistically significant differences in lowering self-reported shoulder problems and improving functional work capabilities. The workplace-based approach incorporated rehabilitative principles of athletic rotator cuff pathology, biomechanics, and specific job activities using actual work facilities in the work environment, minimizing psychosocial workplace factors related to separation from the work routine. A systematic review and meta-analysis found that a weighted average of 62.3% of patients returned to their previous level of work at a mean of 8.15 months after surgery. Higher rates of return to previous work were identified with decreasing work intensity, reaching strong statistical significance, and almost certainly reflecting a true effect rather than chance, while rates were similar between open and arthroscopic repair techniques, showing no meaningful statistical difference between the two approaches. Green and colleagues reported that 89.6% of manual laborers aged 50 to 60 years returned to work after arthroscopic rotator cuff repair, with mean visual analog scale pain decreasing from 8.0 to 0.46 and mean ASES scores improving from 39.58 to 93.44, reaching strong statistical significance and almost certainly reflecting true and substantial treatment effects. Patients who continued working after injury but before surgery were 1.6 times more likely to return to work at any level at 6 months, and patients who nominated their pre-injury level of work as light were 11 times more likely to return to pre-injury levels. Despite these favorable numbers, more than 35% of patients are unable to return to their previous work level after surgical repair, which drives home the importance of realistic expectations and thorough return-to-work support. Return to sport following rotator cuff repair follows a distinct trajectory from return to work. A systematic review identified 9 criteria used to define readiness for return to play after rotator cuff repair, with time from surgery being the most frequently reported criterion at 78% of studies, used as the sole criterion by 54% of studies, while strength and range of motion were the next most commonly reported criteria at 25% of studies. A Swiss multicenter cohort study of 725 patients found that 57.4% achieved full return to sport at 24 months and 43.8% returned to their primary pre-injury sport. Favorable prognostic factors for full return to sport included traumatic injury etiology, which modestly but reliably increased the likelihood of full return, a finding that was statistically significant and consistently supported across the evidence. High motivation to return to sport at baseline, which similarly showed a modest but reliable increase in the likelihood of returning, a statistically significant finding. Higher sports activity levels at 6 months, which showed a small but consistently observed association with better outcomes. And a low depression score at 12 months, which showed a small but consistently observed protective association. For young patients under 45 years, a systematic review found a 75% rate of return to sport at any level and 56% at the same or higher level after arthroscopic treatment, with rates increasing to 80% and 61% respectively when excluding non-athletes and debridement cases. In active duty military patients under 40, 88% returned to full unrestricted activity, with visual analog scale pain decreasing from 8.03 to 1.16 and ASES scores increasing from 41.0 to 88.7 at a mean follow-up of 104.5 months. The American Society of Shoulder and Elbow Therapists recommends that return to athletic or demanding work activities should be based on completion of a functional progression that includes sport or work-specific exercises, with advancement contingent upon meeting all preceding criteria, including full, pain-free active range of motion, symmetrical to the contralateral side, strength of 90% or greater of the contralateral side on isokinetic testing, successful completion of functional performance tests, patient-reported outcome measures within normal or pre-injury ranges, and psychological readiness including confidence and low fear of re-injury. Effective management of rotator cuff pathology requires coordinated interprofessional collaboration, with each provider contributing distinct expertise to the shared goals of pain reduction, functional restoration, and return to meaningful activity. Physical therapists serve as the primary rehabilitation specialists responsible for exercise prescription, progression, and neuromuscular reeducation throughout all phases, addressing parascapular muscle weakness, scapular posture correction, rotator cuff strength and endurance, and glenohumeral range of motion restoration. Occupational therapists translate impairment level gains into functional capacity for activities of daily living and occupational performance, with particular expertise in task-specific multiplanar movement patterns that simulate real-world demands, work simulation, and ergonomic assessment. Surgeons provide operative decision-making, perform surgical repairs, establish post-operative precautions and healing timelines, and provide clearance at protocol milestones. Primary care providers initiate evaluation, avoid routine imaging in the absence of red flags, provide pharmacologic management, and reserve surgical referral for acute traumatic tears, young active patients, or those failing 3 to 6 months of conservative management. Nurses serve critical roles in immediate postoperative care, patient education regarding precautions and healing timelines, pain management coordination, monitoring for complications, and enabling communication between the surgical team and rehabilitation providers. Centralized care coordination is an essential component of effective return to work and rehabilitation programs. The interprofessional team should convene at critical transition points, immediately postoperatively, at 6 weeks when transitioning from passive to active range of motion, at 12 weeks when initiating strengthening, and when planning return to work or sport. Shared care protocols with clear progression criteria support consistent care across disciplines, and electronic health records with shared documentation enable real-time communication. Communication challenges between healthcare providers and case managers can result in injured workers becoming information conduits between providers, leading to adversarial relationships and disengagement from rehabilitation. The IPASS handoff tool, which stands for Illness Severity, Patient Summary, Action List, Situation Awareness, and Synthesis to Receiver, has moderate certainty evidence for reducing medical errors and adverse events, with implementation across 32 hospitals demonstrating a 47% reduction in handoff-related adverse events. A 2025 study published in JAMA Surgery found that patients who reported suboptimal shared decision-making had more than twice the odds of worse mental health scores and pain interference compared to those reporting optimal shared decision-making, independent of whether complications occurred. That finding reinforces the point that the counseling process itself directly impacts patient outcomes. Prognosis in rotator cuff pathology is determined by a complex interplay of patient, tear, and treatment factors. For conservative management, clinically important improvements in pain occur within 6 weeks. Meaningful improvements in disability as measured by the WORC occur within 12 weeks and are sustained through 26 weeks, and at 24 months, 78% of patients with isolated supraspinatus tears achieve improvements greater than the minimum clinically important difference for disability. More than 80% of patients report reduced pain and improved function at 6 to 12 months with supervised physical therapy, and at 10-year follow-up, physical therapy is successful in more than 70% of patients with symptomatic atraumatic full-thickness tears. At 15-year follow-up, the Musmeyer randomized trial showed that differences between surgery and physiotherapy become more pronounced over time, with the constant score, mean difference increasing from 5.3 points at 5 years to 9.6 points at 10 years, a finding that was statistically significant and reliably supported across the study data, and highly unlikely to be due to chance, to 11.8 points at 15 years, reaching strong statistical significance and almost certainly reflecting a true and growing treatment advantage. So while physiotherapy provides durable benefit, surgical repair may offer incrementally greater long-term improvement. Pain self-efficacy is the most important modifiable psychosocial factor, serving as a protective factor against persistent rotator cuff-related shoulder pain at both 12 weeks and 24 weeks. Higher perceived stress, catastrophizing, symptoms of depression and anxiety, and lower resilience are associated with ongoing symptoms. Comorbidities including smoking, which modestly but measurably increases the risk, hypertension, which raises the risk by approximately half, and diabetes are recognized as modifiers of both natural history and treatment response. Rehabilitation professionals should help ensure timely referral to surgical consultation when conservative management fails to produce adequate improvement. Specific escalation criteria include persistent function-limiting symptoms despite 6 to 12 weeks of structured rehabilitation for partial thickness tears or 3 to 6 months for full thickness tears. Failure to achieve minimum clinically important difference in validated outcome measures at expected time points. Progressive loss of strength or range of motion on serial examination. Increasing pain that may signal tear progression, particularly in tears exceeding 1.0 to 1.5 centimeters. Traumatic tears in younger or highly active individuals, and high functional demands with inadequate response to conservative care. Re-tear rates after surgical repair range from 21% after 1 year to approximately 41% at 14-year follow-up, though even patients with re-tears often maintain improved pain and function compared to preoperative status. For conservatively managed tears, ongoing monitoring with periodic clinical reassessment, functional testing, and imaging when clinically indicated is recommended to identify tear progression, and the development of symptoms that may warrant intervention. Module 7 brings together the concepts from the preceding modules into 4 clinically realistic case studies. Our first case involves a 55-year-old right-hand dominant male construction worker who presents with a 6-month history of progressive right shoulder pain that's worsened over the past 8 weeks. He's worked in construction for over 25 years, spending approximately 40% of his workday performing overhead tasks, including framing and drywall installation. He reports lateral shoulder pain rated 6 out of 10 on the NPRS, exacerbated by overhead reaching and lifting, with significant night pain that disrupts sleep. He has a history of hypertension managed with medication, a body mass index of 29, and a 15-pack year smoking history. He reports no discrete traumatic event and no radiating symptoms below the elbow. This patient's risk profile is substantial: age above 50 years, which more than triples the risk of rotator cuff tendinopathy; prolonged overhead occupational exposure exceeding 10 years, which roughly doubles the risk of rotator cuff disease surgery over time; hypertension, which raises the risk by approximately half; elevated body mass index, which modestly but reliably increases the risk; and smoking, which modestly but measurably increases the risk as well. Physical examination reveals pain and weakness with the empty can test and a positive Hawkins-Kennedy sign, with pain-associated weakness in abduction rather than true weakness in the absence of pain, suggesting tendinopathy or partial thickness tear rather than a full thickness tear. Active range of motion is limited in abduction to 140 degrees with pain, and passive range of motion is full. Anteroposterior radiographs are unremarkable. Given the absence of red flags, the absence of true weakness suggesting full thickness tear, and the insidious onset consistent with degenerative tendinopathy, imaging beyond radiographs isn't indicated at this stage. Conservative management is initiated as first-line therapy for this construction worker. The physical therapist prescribes a criteria-based progressive exercise program beginning with isometric rotator cuff and scapular stabilization exercises, with shoulder flexion and abduction restricted between 90 and 120 degrees during the acute phase. Patient education emphasizes that most rotator cuff-related shoulder pain responds well to structured exercise, that pain during exercise within acceptable limits doesn't indicate tissue damage, and that imaging findings in his age group are extremely common, even in asymptomatic individuals. The occupational therapist conducts a worksite assessment and recommends ergonomic modifications including use of extension poles to reduce overhead reaching, task rotation to distribute high-demand activities, and temporary restriction from overhead work. A return-to-work plan is developed collaboratively with the patient and his employer, incorporating graduated return to full duties contingent upon achieving pain reduction with an NPRS decrease of 1.5 or more points and functional improvement with a SPADI decrease of 18 or more points. The primary care provider addresses modifiable risk factors by counseling smoking cessation and optimizing blood pressure management. At 6-week reassessment, the patient demonstrates significant pain reduction to 3 out of 10 on the NPRS and improved active abduction to 165 degrees. Exercises progress to isotonic strengthening at low resistance and high repetitions, 2 to 3 sets of 10 to 20 repetitions, 3 to 5 times per week, with eccentric exercises added as tolerated, exercising into mild pain of 4 out of 10 or less provided symptoms resolve within 24 hours. At 12 weeks, treatment advances to the functional rehabilitation phase, incorporating multi-plane and functional exercises that simulate work demands including overhead reaching, lifting from waist to shoulder height, and sustained arm positioning. Motor control exercises are integrated, as evidence shows these produce a small but meaningful improvement in disability in both the short term and the medium term, supported by consistent findings across multiple randomized controlled trials. The patient resumes modified duties on a graduated schedule. The expected prognosis for this construction worker is favorable with continued structured rehabilitation. More than 80% of patients receiving supervised physical therapy report reduced pain and improved function at 6 to 12 months, and at 10-year follow-up from the Moon shoulder cohort. Physical therapy was successful in more than 70% of patients with symptomatic, atraumatic full-thickness tears. If conservative management achieves adequate pain reduction and functional restoration, a workplace-based maintenance program targeting rotator cuff and scapular stabilizers should continue indefinitely given the patient's ongoing occupational exposure. Predictors of successful conservative management in this patient's profile include the probable partial thickness tear pattern, the absence of fatty infiltration on any future imaging, and high engagement with rehabilitation. If symptoms persist despite 3 to 6 months of optimized conservative management, advanced imaging and surgical consultation would be indicated, with the understanding that even after arthroscopic repair, 90% of manual laborers aged 50 to 60 return to manual labor, with visual analog scale pain decreasing from 8.0 to 0.46 and ASES scores improving from 39.6 to 93.4. Our second case involves a 22-year-old right-hand dominant female collegiate softball pitcher who presents to the athletic training room immediately after experiencing sudden, sharp right shoulder pain during a pitch. She reports hearing a pop followed by immediate inability to raise her arm overhead. She has no prior history of shoulder injury, no metabolic comorbidities, and no family history of rotator cuff disorders. On examination, she demonstrates marked weakness in abduction and external rotation, with inability to abduct above 70 degrees actively despite full passive range of motion. The external rotation lag sign at 90 degrees is positive, and it is highly accurate for confirming the diagnosis when positive, with very few false positives, and is among the strongest diagnostic indicators available for ruling in full-thickness tears. The drop arm test is positive, and it is similarly highly accurate for confirming supraspinatus tears when positive. The combination of acute traumatic onset, sudden significant weakness, and positive high-specificity tests for full-thickness tears generates a high post-test probability for a full-thickness rotator cuff tear. Radiographs exclude fracture and dislocation, and MRI without contrast confirms a full-thickness supraspinatus tear with minimal retraction, no fatty infiltration, and edema consistent with an acute traumatic mechanism rather than chronic degeneration. The acute traumatic nature of the tear in a young, high-demand athlete with otherwise healthy tendon tissue supports early surgical referral, as non-operative management of traumatic full-thickness tears in this population is associated with a 58% treatment failure rate, with 45% ultimately requiring surgical repair. The orthopedic surgeon performs arthroscopic rotator cuff repair with double-row fixation, which is associated with higher healing rates compared to single-row fixation. Postoperative rehabilitation follows a phased, criteria-based protocol. During weeks 0 to 6, the patient is immobilized in an abduction sling with early passive range of motion exercises initiated at 2 weeks, which improve shoulder flexion by a weighted mean difference of 10.57 degrees at 6 weeks compared to brace fixation alone. Nursing staff provide education on sling compliance, wound care, pain management, and monitoring for complications including infection and excessive stiffness. Active assisted range of motion begins at 6 weeks, with active range of motion at 8 weeks. Strengthening exercises begin at 12 weeks, progressing from isometric to isotonic exercises targeting the rotator cuff and scapular stabilizers. The athletic trainer integrates sport-specific functional exercises, plyometrics, and throwing progression beginning at approximately 16 weeks, with advancement contingent upon meeting objective criteria including full pain-free active range of motion symmetrical to the contralateral side, strength of 90% or greater of the contralateral side, and successful completion of functional performance tests. A Swiss multicenter cohort study found that 57.4% of patients achieved full return to sport at 24 months, with favorable prognostic factors including traumatic injury, etiology, which modestly but reliably increased the likelihood of full return, high motivation to return to sport, which similarly showed a modest but reliable positive association, and low depression score at 12 months, which showed a small but consistently observed protective effect. This patient's young age, traumatic etiology, high motivation, and absence of comorbidities are all favorable prognostic indicators for return to competitive play. For patients under 45 years of age, a systematic review reported a 75% rate of return to sport at any level and a 56% rate at the same or higher level after arthroscopic treatment, with rates increasing to 80% and 61% respectively when excluding non-athletes and debridement-only cases. Expected timelines for return to activities after surgery follow a predictable trajectory. Low-level range of motion activities resume within approximately 2 months, simple strength-related activities within approximately 10 months, and sports and leisure activities within approximately 14 months. Long-term surveillance is warranted, as re-tear rates after surgical repair reach approximately 41% at mean 14-year follow-up, though even patients with structural re-tears often maintain improved pain and function compared to their preoperative status. Our third case involves a 72-year-old female who undergoes an MRI of her right shoulder as part of a workup for neck pain. The MRI incidentally reveals a full-thickness supraspinatus tear, measuring approximately 1.5 centimeters with mild fatty infiltration, but no significant retraction. She reports no shoulder pain, no functional limitations, and no history of shoulder trauma. She's independent in all activities of daily living, lives alone, and is active in her community. This scenario is remarkably common. The AAOS guideline reports that 54% of asymptomatic patients over 60 years demonstrate rotator cuff tears on imaging, and the FIMAGE study found that 78% of full-thickness tears were identified in asymptomatic shoulders. After adjusting for confounders, the difference in full-thickness tear prevalence between symptomatic and asymptomatic shoulders showed no meaningful statistical difference, a finding that was consistent across the data, and strongly suggests that imaging alone cannot reliably distinguish symptomatic from asymptomatic shoulders in this age group. This patient's imaging finding represents an incidental finding that doesn't warrant intervention in the absence of symptoms. The primary care provider communicates the imaging findings using evidence-based framing, explaining that rotator cuff structural changes are extremely common in people her age who have no shoulder problems, that the finding doesn't indicate a need for surgery, and that it represents a normal age-related change rather than a disease process requiring treatment. The term tear is avoided in favor of structural change or age-related alteration to minimize nocebo effects, as research shows that the label rotator cuff tear increases perceived need for surgery by 0.7 points and perceived need for imaging by 1.0 points compared to more neutral terminology. The clinician explains that if shoulder symptoms develop in the future, exercise-based treatment is effective for the vast majority of patients, with more than 80% reporting reduced pain and improved function at 6 to 12 months with supervised physical therapy. A monitoring plan is established that includes periodic reassessment if symptoms develop, with the patient counseled that tear enlargement occurs in 60% of shoulders over a median of 7.1 years, and that pain develops in 57% of asymptomatic tears over time. However, a randomized trial in patients older than 55 with small, non-traumatic supraspinatus tears found no significant differences in outcomes between conservative and operative groups at over 5-year follow-up, and operative treatment didn't protect against glenohumeral osteoarthritis or cuff tear arthropathy progression. The physical therapist provides a preventive exercise program targeting rotator cuff and scapular strengthening, with the occupational therapist assessing for fall risk factors and recommending strategies to maintain functional independence. The nurse reinforces that the patient should continue all normal activities and return for evaluation only if shoulder pain, weakness, or functional limitation develops. Understanding the natural history of this patient's incidental finding is essential for appropriate long-term planning. Full-thickness tears are at substantially greater risk for enlargement than partial-thickness tears, with roughly triple the risk of progression, and survivorship free of tear enlargement for full-thickness tears declines from 74% at 2 years to 42% at 5 years and 20% at 8 years. Partial thickness tears progress to full thickness at a rate of 0.26% per month, with symptomatic patients demonstrating higher progression rates of 33% to 63% compared to 4% to 38% in asymptomatic patients. Should this patient develop symptoms in the future, the interprofessional team should initiate conservative management as the first-line approach, recognizing that at this patient's age, the goals of treatment center on maintaining independence in activities of daily living, preventing falls, and preserving quality of life rather than achieving high-demand functional outcomes. Rehabilitation progression in elderly patients should proceed more slowly, with frequent reassessment and integration of occupational therapy to address functional independence and home safety. Our fourth case involves a 48-year-old right-hand dominant male painter who presents to the occupational health clinic with a 3-week history of right shoulder pain that began gradually without a specific injury. He reports pain with overhead painting and difficulty reaching behind his back. He's worked as a painter for 18 years, spending approximately 50% of his workday with his arms above shoulder level. He has well-controlled type 2 diabetes, a body mass index of 27, and no smoking history. His pain is rated 4 out of 10 on the NPRS and worsens toward the end of the workday. The occupational health nurse recognizes this patient's elevated risk profile. Prolonged occupational exposure to overhead work with duration exceeding 10 years, which roughly doubles the risk of rotator cuff disease surgery over time. diabetes, which roughly doubles the risk of rotator cuff tendinopathy, and work with the shoulder above 90 degrees, which carries approximately 2.5 times the risk. The nurse performs a focused screening examination including the painful arc test, the empty can test, and resisted external rotation, finding pain but not true weakness, consistent with rotator cuff tendinopathy. No red flags are identified. The nurse enables prompt referral to physical therapy for evaluation and treatment, and initiates communication with the employer regarding temporary work modifications. The occupational health nurse coordinates a multi-domain intervention spanning health-focused treatment, service coordination, and work modification, which evidence shows significantly reduces duration away from work for musculoskeletal conditions. Temporary workplace accommodations are implemented immediately. The painter is reassigned to lower-level tasks that don't require sustained overhead work, and extension poles are provided for necessary overhead painting. The physical therapist initiates a criteria-based progressive exercise program with isometric exercises in the acute phase, educating the patient that pain during exercise within acceptable limits is expected and doesn't indicate worsening damage. The occupational therapist conducts a worksite ergonomic assessment and recommends task rotation using an upward parabolic sequence to minimize cumulative fatigue, workstation modifications to reduce overhead reaching, and use of mechanical assists. The nurse reinforces best practice education messages at each follow-up visit, emphasizing that shoulder pain associated with work isn't serious and responds well to active management, that continuing with daily activities within pain limits is safe, and that structured exercise is the most effective treatment. The nurse monitors the patient's diabetes management, recognizing that corticosteroid injections may transiently worsen glycemic control, and communicates this consideration to the treating physician. At 6-week follow-up, the patient reports pain reduction to 2 out of 10 on the NPRS and is progressing through the strengthening phase of rehabilitation. A graduated return to full duties plan is developed collaboratively among the occupational health nurse, physical therapist, occupational therapist, and employer, with the goal of achieving full return to painting duties within 12 to 16 weeks, contingent upon meeting objective criteria, including pain-free active range of motion and strength of 90% or greater of the contralateral side. The nurse establishes an ongoing monitoring protocol given the patient's continued occupational exposure, with annual symptom-based reassessment and reinforcement of preventive exercise and ergonomic strategies. This case illustrates the critical importance of clinical reasoning when special tests conflict with the clinical presentation. The occupational health nurse follows a systematic process, first analyzing the history and symptom pattern including pain location, temporal patterns, and range of motion characteristics. Then conducting discriminatory physical examination, including cervical spine screening and a acromioclavicular joint assessment to exclude referred pain, and finally applying Bayesian clinical reasoning to estimate pre-test probability based on the patient's risk factor profile before interpreting test results. The nurse recognizes patterns requiring immediate referral, including acute traumatic onset with inability to move the arm, visible deformity, or rapidly progressive weakness, none of which are present in this patient. The expected outcome for this patient is favorable. Workplace-based rehabilitation programs that incorporate actual work demands produce significantly higher return-to-work rates at 71.4% versus 37% compared to clinic-based rehabilitation alone, with better psychosocial adaptation. The occupational therapist contribution is particularly valuable here, as occupational therapy services after rotator cuff intervention are associated with 16.9% fewer visits, 13.8% shorter episode lengths, and 13.4% earlier therapy initiation compared to physical therapy alone, suggesting that task-specific functional training may accelerate recovery in occupational settings. Communication failures remain the most frequent root cause in sentinel events, with failed handoffs implicated in an estimated 80% of serious preventable adverse events, which highlights the importance of the nurse's coordination role in maintaining clear communication channels among all providers involved in this patient's care. We will now review the exam questions to solidify your understanding. Question 1. According to the FIMAGE study, what percentage of adults aged 41 to 76 years had at least one structural abnormality on MRI? The correct answer is D, 99%. Rationale. The FIMAGE study, published in JAMA Internal Medicine, found that 99% of adults aged 41 to 76 years had at least one rotator cuff abnormality on MRI, making it the most thorough population-based MRI data to date. Question 2. Approximately how many rotator cuff repairs are performed annually in the United States? The correct answer is B, 250,000. Rationale. The course states that approximately 250,000 rotator cuff repairs are performed annually in the United States, with more than 2/3 of patients being of working age. Question 3. Which umbrella term does the 2025 JOSPT Clinical Practice Guideline recommend for clinical diagnosis of shoulder pain suspected to originate from the rotator cuff? The correct answer is C, rotator cuff-related shoulder pain. Rationale. The 2025 JOSPT Clinical Practice Guideline recommends rotator cuff-related shoulder pain, also known as RCRSP, as the primary umbrella term. It was the overwhelming first choice in a global survey of clinicians and provides a patient-centered symptom-based diagnostic label. Question 4. Which cluster of tests does the JOSPT guideline recommend for identifying full-thickness rotator cuff tears? The correct answer is A, drop arm test, external rotation lag sign, and the combination of the near sign with the drop arm test. Rationale. The JOSPT guideline recommends the drop arm test, external rotation lag sign, and the combination of the near sign with the drop arm test as the cluster for identifying full-thickness rotator cuff tears. The external rotation lag sign is among the strongest diagnostic indicators for ruling in full-thickness tears. Question 5. In the physical examination of rotator cuff pathology, what is the critical clinical distinction in strength testing? The correct answer is C, the difference between pain-associated weakness and true weakness in the absence of pain. Rationale. The critical clinical distinction in strength testing is between pain-associated weakness, which is more common in tendinopathy and partial thickness tears, and true weakness in the absence of pain, which is highly suggestive of a full-thickness tear. Question 6. During the acute phase of rotator cuff management, which type of exercise is preferred initially because it provokes less pain and maintains neuromuscular engagement without excessive tendon loading? The correct answer is B, isometric exercises. Rationale. Isometric exercises are preferred initially during the acute phase because they provoke less pain and maintain neuromuscular engagement without excessive tendon loading. The majority of clinicians recommend isometric exercises during this initial phase. Question 7. According to the course content, what is the strongest predictor of successful physical therapy, defined as avoidance of surgery? The correct answer is A, high patient expectation regarding its effectiveness. Rationale. The strongest predictor of successful physical therapy, defined as avoidance of surgery, is high patient expectation regarding its effectiveness. This finding was demonstrated by the Moon Shoulder Prospective Cohort and highlights how critical it is to foster positive expectations during counseling. Question 8. In a study of patients with traumatic full-thickness tears who initially underwent non-operative treatment, what percentage experienced treatment failure? The correct answer is D, 58%. Rationale. A retrospective study found that 58% of patients with traumatic full-thickness tears who initially underwent non-operative treatment experienced treatment failure, with 45% ultimately requiring rotator cuff repair after an average of 6 months of conservative management. Question 9. According to the course content, what was reported about occupational therapy services after rotator cuff repair compared to physical therapy alone? The correct answer is B. Occupational therapy services are associated with fewer visits, shorter episode lengths, and earlier therapy initiation. Rationale. The course states that occupational therapy services are associated with 16.9% fewer visits, 13.8% shorter episode lengths, and 13.4% earlier therapy initiation compared to physical therapy alone, despite only 5.2% of patients receiving occupational therapy after rotator cuff repair. Question 10. In a randomized controlled trial comparing clinic-based and workplace-based work hardening for work-related rotator cuff disorder, what was the return-to-work rate after 4 weeks for workplace-based rehabilitation? The correct answer is C, 71.4%. Rationale. A randomized controlled trial showed that workplace-based rehabilitation resulted in a significantly higher return-to-work rate after 4 weeks at 71.4% compared to 37% for clinic-based work hardening, with statistically significant differences in lowering self-reported shoulder problems and improving functional work capabilities. That concludes our exam review. Thank you for your dedication to professional development, and we wish you the very best in your continued clinical practice.